This conference will now be recorded.
So we're going to be covering the patient assessment, like the techniques of how things work. Basic review, but I want you guys to take it to that next level, that advanced life support assessment, more in depth, taking what you learned in human body, taking what you learned in pathophysiology, taking all that together and putting that towards your assessment. So when you're feeling things, when you're assessing, when you're taking vital signs, you have more of a deeper assessment than the normal EMT would have. You got to take that next step, and that's where the basics come from this presentation. And then once we start talking about like cardiac, respiratory, then we're going to go more in depth by adding medications into that, and also by adding the actual hands-on physical assessment of how we're going to do things. Right. So this kind of goes into the scene size up, the primary and secondary assessment, patient history, reassessment. This is really a guide to emergency management, as you can see here. So we have some competencies we have to find, obviously applying the information of the patient assessment findings to what I just spoke about. And then looking at the scene size up, scene management. So when you move up in license level, now you're looked more towards more as like a leader, right? A lot of systems run advanced basic or paramedic advanced PA trucks, PB trucks, AB trucks. Not a lot of services still run truly the double basic unit unless they're doing interfacility transport, or they're a smaller community where they can't afford, the towns can't afford to pay in having that advanced life support. But your bigger systems run advanced basic or paramedic advanced or what it may be. So you're looked at as the person with the answers now. So that new EMT that's there is to look up to you as an A and say, hey, I don't know about this. What do you know? You know, they're going to look for that in more in-depth assessment from you, and that more of an advanced baseline knowledge of pathophysiology, A&P, the human body. So we look at scene management, impact on the environment on patient care, addressing hazards, violence, the need for additional specialized resources. And because you're moving up to the advanced in your system, you should know your system a little bit better now. Multiple patient situations, how we deal with the MCI or the small MCI, standard precautions. We're going to go into the primary assessment, looking at level of consciousness, ABCs, identifying life threats, assessment of vital functions, initial general impression. This stuff sounds familiar, right? Pretty similar to the EMT. Right? You guys starting to see the trend?
Yes.
Yes, right? Yeah, this is EMT stuff, but then we take that next level. Begin interventions to preserve life. Interventions including cardiac monitoring, IV therapy, fluids, medications, things that are above and beyond that EMT level. And the integration of treatment protocols needed to preserve life. So we're going to take the differential diagnosis, which we'll talk a lot about tonight, and incorporating differential diagnosis with your treatments to come up with a true diagnosis and a treatment plan. We're going to do history taking, determining chief complaint, mechanism of injury or nature of illness, associated signs and symptoms, right? Investigation of the chief complaint. And a lot of people have heard in other classes I've ever taught before, I talk about interrogation. And really, we're interrogating patients to get that information out to be able to function appropriately to come up with a treatment plan. Pertinent negatives. Does the patient have any chest pain? No. Shortness of breath? No. Pertinent information that has a negative response that helps with your assessment. Secondary assessment, performing a full rapid body scan, head to toe. Or are we doing a focus assessment of pain? So if I have knee pain, abdominal pain, right? Obviously, I'm not going to be checking in the patient's foot if they have severe abdominal pain. I'm going to focus on the abdomen. And we're going to go more in depth of locating organs and whatnot and saying, okay, well, this is here, or this referred pain goes here. And this is how we're going to be able to treat the patient, looking at the assessment of vital signs with them. Looking at the techniques of the physical exam, we have the respiratory system, presence of breath sounds, looking at a cardiovascular system, EKGs, 4-lead, 12-lead, neurologic systems, going more in depth on our stroke assessment, all right? musculoskeletal system, hands-on. Take your time doing the assessment. Find out where damage is being done. Looking at all anatomic regions. Assessment of lung sounds, you need to do a deeper assessment. Truly listen to the patient's lungs. Because that could be life or death based on what medication you administer to this patient. Looking at different monitoring devices. So now instead of just using blood glucose at the EMT level, obviously placing an EMT, placing a cardiac monitor as an EMT, now we're going more in depth on looking at the rhythm and saying, this is a sinus rhythm. This is a sinus tachycardia. This is sinus brady, VTAC, VFib, asystole. Looking at these different rhythms that we're going to see in front of us. Again, don't be afraid of this stuff. We're going to get into cardiology. Don't worry. We'll make sure we hit that stuff pretty well for you guys. Looking at pulse oximetry, non-invasive blood pressure. Okay, so getting out of the manual blood pressure does not mean that the manual blood pressure goes away. Right? Manual blood pressure in your ears are better than using a cardiac monitor for non-invasive monitoring that way. Right? We're going to look at end-tidal CO2, blood glucose determination, how we're going to treat it based on hyper and hypoglycemia, because now we carry medications to dilute blood and or give medications like D10 or D50 to increase someone's blood sugar versus just saying, oh, here's a tube of oral glucose. And then the reassessment of how and when to reassess a patient. And what do we do with that? And how to perform a reassessment for all patient situations. So let's get into the patient assessment process. After I scratch my eyeball. All right, we're good. All right, so patient assessment process. Scene size up. You must master and be comfortable with the patient assessment process. You're moving into the AEMT realm now, which means you've mastered the EMT assessment. That's why we're here, take that next step. Patient assessment is used in every patient encounter. So is there a patient encounter you walk in to do a patient lift assist? No injuries, patient on the floor, just says, yeah, I slipped out of bed. Are you doing an assessment on that patient, yes or no?
Yes.
Yeah, how?
Yes.
How? What are you doing? What do you do? I mean, what do you do for an assessment?
See what was going on prior to them falling?
Okay, so now it's part of your scene size up and your history taking, right, George? Yeah, exactly.
Right.
Okay.
I'm checking them out head to toe.
But what if they say, you know what, I'm all set. Just help me up. I don't need any vital signs taken. I don't need a blood pressure. Does that mean your assessment stops, or are you still assessing the patient? I like what
It's
Mike
still
told.
visually assessing.
You're doing a really decent assessment without doing hands-on. And Mike made a good point. LOC, AVPU, ABCs, right?
Yeah.
So Jen, I'm having a conversation with you right now, right? What am I picking up from you? I'll tell you what I'm picking up. I'm picking up the fact that you're having a full conversation. Therefore, you are speaking in full sentences. You're not in respiratory distress. If I'm looking at you and your skin looks pink, warm, and dry, I know that you're not having any issues with signs of struggle of circulation. Okay. By having you talk to me and being coherent, now I know you're alert and oriented, right?
Right.
All part of that assessment. Then we bring in our Glasgow Coma scale, and you have a GCS of 15 because we're having that conversation. You're alert, oriented, good. If I'm with you in front of you, you have good eye movement, good motor functions. You have good verbal response back, which is a GCS of 4, 5, and 6, which equals 15, and that's the number we're looking for. Right? I just did a pretty decent assessment just by having a conversation, right? And these are things you need to document in your run report. This is that next level stuff that I'm talking about. To be able to walk in before you even get hands-on, you can say, that patient looks sick. That patient looks not sick. We have time to stay and play or shit and get. What are we going to do? By walking in and having that initial impression.
I was just going to say, I'm pale, warm, and lethargic. You
If
can
you're
keep going if you want.
lethargic, but I got to look at other things too as well, right? Then I
I've been
start
sick
asking
since last
questions,
night.
but then I'll start asking you more questions about it,
Yeah.
right? Really, our job moving up from advanced EMT to paramedic is not just doing the basic skills. We can never forget about our basics. Never forget about the basic level stuff. But we're trained to learn better with body systems. Now let's ask
Mhm.
questions based on those symptoms in those systems, okay? So scene size up. When does scene size up truly start?
As soon as you make patient contact.
Okay, that's what you. Okay, that's Jen. You said patient contact. Mike is saying time of the call. Be
Yeah.
more specific. Be more Kenny, Mike. More specific on that, though.
From point
Time
of
you're
dispatch.
dispatched.
The time you are dispatched is when you start doing your size up, right? Scene size up starts when the dispatch goes out. 56-year-old female complaining of chest pressure. I'm starting my size up. I'm thinking in my head, what am I going to do when I walk through the door? What am I bringing inside with me? All right. If Matt Harrington and I are working on a truck together in Massachusetts, I'm gonna look at Matt and say, I got the monitor, you got the first in bag. Okay. We work together as a team. We start planning and assessing what we're going to be doing or planning for the assessment. So when we get inside, we're not going to be caught with our pants down and say, oh crap, we should have brought this in. We plan it based on our size up. As we approach the scene, we look at what are we looking for when we approach the scene. This is paramedic level stuff I'm teaching you guys. Okay. Yeah, I know we're in AEMT class. I got it. But walking in, looking at this stuff, what do we look for when we pull up to a scene?
Scene
Uh,
safety.
Okay, elaborate more on that.
when we pull up to a scene, I'm looking at what does the house look like? What's the temperature in the air? What's the temperature outside? Is it raining out? Is the yard clean and well kept? Is the house clean and well kept? When I get inside the house, I'm looking at the temperature of the house. Is it a normal, comfortable temperature, or is it too hot? Is it too cold? I'm looking at, is the inside of the house clean and well kept? Or is it in disarray and falling apart? And am I looking at a hoarding situation?
Right.
Um,
So Matt, I'm going to stop you there for 1 second. All right.
okay.
So I got Matt O'Connor saying danger. Okay. Perfect. Looking for dangerous situations. The best entrance and egress and how we're going to get out if there's a problem. Right. How many steps are going to be going up into the residence? Right. We've just assessed the hell out of this already. Right. Before patient contact. So that is part of scene size up. Does scene size up ever stop? Never. No. Never stops. Right? I didn't mean to take your thunder away from you, Matt. But you were on a roll and you were doing good. Right? So
Thank you.
we just talked 5 minutes about scene size up, what we're going to do. We're not even on a survey yet. Right? So these are the things that we're doing. It never stops. Looking around for our safety, right? Looking around for weapons. How the patient's body language is when you walk through the door. Right? Let me look at our primary survey. What's going on? Patient sick or not sick? Right? Let me get into the primary survey of that. We look at our ABCs. We look at they can speak in full sentences. If they have two-word dyspnea, is that normal?
No.
No. That's significant respiratory distress, right? Two-word dyspnea, and that should be in your run report. That should determine if a patient has a history of COPD, they have two-word dyspnea. We start doing our assessment, and they say, "I can't catch my breath." What do we need to do for them? What are we doing? Okay, Tandra says oxygen. Yeah, they need to be oxygenated, right? So we get it. So giving O2, getting our full assessment. Quick set of vital signs, pulse oximetry, and I tell you the pulse ox is 60%. What's next?
Thanks.
What can you do to fix that problem?
Ventilate.
Okay, or they're alert, they're oriented, they can maintain their own airway. What's next?
Sit them up, give albuterol.
Okay. What else can you do to help oxygenate that patient?
Give them oxygen.
What else can we do to oxygenate that patient? I'm going to keep asking the same question. Reason why I'm asking you the same question over and over again, guys, is because this is an EMT skill in Massachusetts, in Maine, in New Hampshire.
Should I talk them through it?
Mhm.
What procedure can we do to them?
Put them on a nasal cannula or a non-rebreather.
Mike Ball has it correct.
Mhm.
CPAP. Why are we not doing CPAP in the house? There's not one person in this class who can give me a good answer to that because there isn't one. Why are we not bringing our life-saving devices into a home? It's part of our scene size up. If we get called for respiratory distress, bring the tools you need inside. Right? Latondra says it will suck the tank dry. Correct, it will.
Hmm.
Right? Depending on which system you use, right? And it all depends on the system. But if I had a pulse oximetry at 60 and I was breathing at 2 times a minute, sorry, rephrase that. I was speaking to her dyspnea, I would want you to fix me now and not 10 minutes or 15 minutes from now. And you can do inline nebs, DLS level, inline nebulizers with CPAP, right? These are things we got to start thinking about on our primary survey. Is this patient sick? Do they need something? CPAP is like giving somebody D50. It will turn them around very quickly, right? CPAP is such a great device that it has reduced the number of intubations in hospitals for patients in COPD exacerbation. Early onset CPAP. Primary survey, and I wanted to put that into perspective on a patient assessment. Primary survey is when we start saying life-threatening information. Okay, life threats, A, B, C. Right? Then we get into our history taking. Yeah, is it going to be harder to hear this guy talk? Absolutely. Absolutely it will be. But at least they can talk to you. What are we doing for history taking? We're going to go over all this multiple times. Okay. What's a history taking? What do we do? What are we looking for? Give me something.
History of respiratory issues. Was he ever intubated before?
Okay. Good questions.
Is he taking medication for that respiratory issue?
Yep. So how do we find this out? Sean Edmond put it down in our group. Sample history. Signs and symptoms, allergies, medications, past medical history, last oral intake, events leading to illness or injury. Mike Ball, perfect. OPQRST, onset, what provokes it, quality, radiation, severity, time. All this stuff is very important. If you have a patient who is difficulty breathing and you hear crackles in the lungs, crackles, you hear rales, not rhonchi, but rales, are we going to start giving these people nebulizers? Everybody should be saying, we haven't covered this much yet, but you should be saying no. Okay? We don't want to give them nebs. These patients need CPAP. These patients truly need nitrates, right? But if I said the same thing, you heard rhonchi and wheezing, yes, absolutely. Bronchodilation, right? Now we got mucus buildup, not fluid, right? So history taking, sample, OPQRST, get this information out. Then you do your secondary assessment, head to toe or focus assessment on that. Lung sounds, reassess lung sounds after treatments, right? Do we need to go? We need to put an IV in place. Any patient that has respiratory distress gets a 12 lead. Any patient with respiratory distress gets a 12 lead. Why?
There could be a underlying cardiac issue.
Okay. Could be an underlying cardiac issue causing that. I see Mike saying cardiopulmonary. Could be a cardiac issue. Kenny, let's see. Tondra, it taxes and strains the hearts. I like it. Go more in depth with it, though. Keep going. How does it tax and strain the heart? Kobe, could be bigger issues. Very well could be underlying. Respiratory distress could be a STEMI. But how is it straining the heart? I want to know more. Heart has to work harder to oxygenate the blood because we aren't getting enough O2 into the bloodstream. Right. We're setting at 60%. Our body gets pissed off, and as our heart gets pissy and says, oh my God, we're going to start developing chest pain. We're not oxygenating the cells appropriately. Exactly. So by putting somebody on CPAP, what is that doing for them?
It pushes the fluid out of the way to allow more oxygenation.
Yes. For CHF, absolutely. It pushes the fluid out of the lungs to allow for the alveoli to provide better gas exchange, right? But a person that has COPD exacerbation, now it's not fluid, right? Now that it's constricted, now what? What is that special thing that CPAP does? Let's start with this. What does CPAP stand for?
Isn't it special because it's continuous?
Continuous pressure. I can't remember the rest of it.
Okay, continuous. P is positive. A, airway pressure. So Rosa, you had that right. And George, you were almost there with it. Okay, continuous positive airway pressure. And by doing so, it creates what? What does continuous positive airway pressure create?
Oxygenation.
And it helps oxygenate because of
Pressure in the alveoli.
okay. And how do the lungs stay open longer to do that?
PEEP.
PEEP. Exactly. I'm not talking about the little yellow marshmallow things on Easter. The positive pressure keeps forcing them open. PEEP stands for positive end expiratory pressure. Okay. This is the next level of information you guys need to know. Cause and effect. Cause and effect. If I do this, what's going to happen? Right? So we get all this stuff done. We get our IVs. We give nebs. We keep moving through all this. Right? Now we do our reassessment. Okay? A patient that is breathing with CPAP and everything else, how often do we reassess the patient?
Every 5 minutes.
Yeah, absolutely. Every 5 minutes. Because this patient right now is not very stable. They're hopefully going to stabilize with everything we're doing for them at the advanced level, but they're not quite there yet. Every 5 minutes. All right. So signs or objectives or conditions you observe, okay? Remember, a sign is what you see. A symptom is what the patient tells you. Remember, you can see a stop sign. You can't see a symptom, okay? So look at your signs and symptoms, objective and subjective information to help formulate your plan, okay? The difference in your findings is how you effectively care for your patient. We have to do evaluation. If everybody took a piece of paper out and a pen or a pencil and drove an upside down pyramid, okay? Think of that bottom peak upside down pyramid as your diagnosis. And everything on the top, that flat, long surface, is everything it potentially could be. And you do differential diagnosis with the treatments or with the tools that you have to come up with a treatment plan and a diagnosis in an EMS that happens in 3 minutes. We have to come up with a diagnosis fast. The longer we sit there, the worse the patient's going to get. So we have to take our objectives, our subjective information. The chief complaint. Why did you call EMS? What they tell you is their chief complaint. What dispatches you out for is not a chief complaint. It's what you were dispatched for. Okay? Why were we called to this patient? Looking at critical thinking skills. Effective clinical decision making depends on your ability to do the following: gather information, evaluate what we have, and synthesize patient information to come up with a plan. We're going to develop that idea of the patient's problem in our head and formulate a field impression, okay, otherwise known as a diagnosis. In every assessment, practice critical thinking skills. Differential diagnosis, reverse pyramid effect. Gather the information, observe the scene, and question the patient and bystanders, right? Evaluate the information you have. Consider the meaning of the gathered information and prioritize them accordingly. Synthesize that information by collecting all the evaluated data and form a plan to manage the scene and or the patient. Then we talk about integrating the information you obtain regarding the current incident with similar situations and experiences. The longer you've been doing this, the more solid of a provider you will become. Because now you're going to be taking what you said, okay, well, I had 2 weeks ago, I had a patient in this. This is very similar, and this is how I treated them. So I'm going to kind of go down that road until something else tells me not to, right? This is why interfacility transport is so important, even with BLS discharges, because you take that time to read the discharge summaries. Then you have a 911 call, and you see that same presentation of what you read in the discharge summary, and you kind of have an idea of where that plan may go. So for people that tell me this, that I am too good for interfacility transport, then you are a piss poor provider. Flat out. That's my soapbox that I have. Nobody is too good for a transfer because you can learn so much information from the paperwork that is provided to you. Remember, you're taking them out of a hospital and bringing them home. Well, the thing is they were there for a reason. They were sick. So let me read about it. So the next time I come up with a presentation like that again, I can be like, holy crap, I think I know what's wrong with this patient. Does that make sense, everybody?
Yes.
Yeah. Right? Don't be that mediocre provider. Strive to be the best every single day. Right? Articulating assessment-based decisions and construct arguments. We are in a system of assessment-based management, right? That's what we're doing. Evidence-based management, evidence-based medicine. Everything we do is based on evidence. We talked about that earlier on in the program. Integrating the information you obtain regarding the current incident with a similar situation and experience, like I just said before. Defending your actions and justifying the decisions on which you base your treatment. Factors that can hamper the ability to perform emergency medical care usually does not exist in other medical settings. Always base your treatment and transport decisions on your assessment of the patient. Nobody can be better than what your brain, what your mind can do. You have all these tools provided to you, but your best critical thinking does not come from a cardiac monitor. That's a tool that helps you gather information to do your evaluation, to synthesize the information, to develop a plan, and formulate a field impression for treatment. Right? So, again, scene size up, information gathering stage from the time of dispatch throughout the entire call, because things change. Continuous situational awareness is necessary throughout the call. So pay attention to the conditions and people around you at all times. situations can change. Vehicles can appear out of nowhere. Okay. Consider environmental conditions. Okay. Matt Harrington mentioned that earlier. Looking at the environmental conditions that are there: rain, snow, sleet, dark, light. That all plays a difference in our patient assessment, our size up, because it may change how we get a patient out of the house. Prepare for a specific situation based on the initial dispatch. Consider a variety of factors that will impact how you operate the scene and provide patient care. So looking at road, traffic hazards, incident hazards. Okay. If you walk up to a residence and you see 6 people unconscious in the home, should we be going in? Or is that what we call a red flag?
No,
Red
it's
flag.
really a red flag.
Exactly. Something's not right here. It's a clue. Imagine that, right? So scene size up must combine an understanding of the situation based on the information the dispatcher provides with your observation of the scene itself. Blue's Clues, exactly, right? It's a clue. Imagine that, something we shouldn't be doing, right? Something's just not right, right? It's that whole spider tingle thing. Yeah, I just said that. Moving forward. All right. So ensure every pre-hospital scene has potential for injury, whether it be the patient or us bystanders doing stupid things, because that's what keeps us in business, right? Ensure safety for yourself and your partner first. Other responders and bystanders second. Your patient is last. The last thing we need is more patients. Okay, that puts us in a bigger predicament. Look for possible dangers as you approach the scene and before you step out of the vehicle. Please look both ways before you get out of the vehicle. Dangerous things happen, right? Hazards found at the scene include traffic, chemical or biologic agents, downed power lines, lightning, secondary collapse, fire, explosions, carbon monoxide, unstable surfaces. Remember, when gaining access to a patient, remember that you will typically leave via the same route you entered. So moving heavy stretcher patient, okay, you're probably going back out the same way. Not all the time, sometimes that happens. Take your time, stay focused on what you are doing, but do not get tunnel vision. Keep your mind open, situational awareness all the time. Protect the bystanders from becoming patients. Be aware of the scenes that have potential for violence and request assistance of law enforcement personnel if required. And move to a safe location or call for additional resources. Determine the MOI or NOI. So do not immediately categorize your patient as either a trauma or a medical. It could be both. You respond to a motor vehicle accident. You look inside and you see a half uneaten candy bar. You see a lot of blood everywhere. Is that a trauma?
Possibly.
Was that?
Said it could be possibly trauma, or it
Okay.
could be a diabetic emergency.
Diabetic emergency that caused the accident that then put trauma on the patient?
Yeah, could be. I mean, that's where you could get, some signs from.
Yep. Exactly. Medically induced trauma. Absolutely. Pick up on the indicators that you see. Half uneaten candy bars or half eaten candy bars. A syringe next to the patient with a vial of insulin. Okay. Look at all the indicators. Consider the mechanism of injury and nature of illness early. It will help you prepare for the rest of the reassessment that you have. You need to be able to identify all the aspects of the emergency to which you were called to respond. MOI. Traumatic injuries are the result of physical force applied to the outside of the body. Classified according to the type and amount of force applied, length of time the force was applied, and where it was applied on the body. The MOI describes how the patient became injured. Keep that in mind. Determining the MOI will provide many clues to help you focus your assessment. It doesn't mean it wasn't something medical. Okay. You got a vehicle off into the woods, you got a patient unconscious. but there's no steering wheel deformity, there's no spidering of the windshield isn't even cracked, you have maybe 6-inch intrusion to the front of the vehicle where it hit the tree. Patient's unconscious. Are you thinking trauma? Or do the clues not make any sense?
Wouldn't make
Clues
much
don't
sense
make
if there
sense.
was.
So do you think it was a medical condition that caused it? Probably,
Possibly.
maybe. But that's our general impression. That's not the full assessment. That's just what we're thinking at the start. But don't go down that path. Do not go down that tunnel vision of it being strictly medical. Because maybe it is something trauma. Maybe they weren't seatbelt, but hit their chest off the steering wheel, and maybe they have a pacer defibrillator and dislodged it, and maybe the heart stopped. Who knows, right? It's all part of our assessment. Don't rule things out. Always keep that suspicion, or index of suspicion, I should say, in the back of your mind. With blunt trauma, the force of the injury occurs over a broad area, and then the skin is not broken. With penetrating trauma, the force of the injury occurs at the specific point of contact between the skin and the object. Anything that's open has a high risk of infection. Right? High risk of infection. And that is why you're starting to see antibiotics at the paramedic level in the field now because of this. We're able to get the first round antibiotics quickly. Nature of illness. Make an effort to determine the general type of illness or nature of illness. Examples would be seizure, heart attack, diabetic condition, poisonings, right? Poisonings, looking at toxidromes, seizure or history without history. What caused the seizure? Was it traumatic? Was it an impact seizure? What type of seizure was it? Tonic, clonic, absent seizure? If it's a heart attack, EKGs. Do we see elevation, depression? We look at a lot of different things. Where does the pain go? Utilizing OPQRST. Diabetic, check a blood sugar, right? Nature of illness is often best described by a patient's chief complaint in medical history, which means we have to talk to our patients, we have to touch our patients appropriately, and move forward. Use your senses to check the scene for clues to the possible cause of that illness. Look around. What's causing? Take standard precautions. Right? Assume that all blood or bodily fluids except sweat, non-intact skin, mucous membranes may pose a substantial risk of infection. I don't think I need to hit this very hard. PPE, protect yourselves. This is BLS. Okay. Determine the number of patients. Put a mass casualty plan into action in case of multiple patients. So let me finish this first, and I'll ask you a question. Consider additional backup or specialized resources, whether that be ALS backup, fire departments, tech rescue, law enforcement. What do we need? Ambulance strike teams, task force, right? Before we get more into the additional resources needed on the MCI stuff, what is the definition of an MCI?
More patients than the oncoming crew can handle on their own.
Right. So Mike's anything that overwhelms the system. George, you got it right too as well. Patients exceed resources. Matt O'Connor said that. More patients than available resources. That was from Tanya. You guys are all correct. More than we can handle at that time. So an ambulance shows up, you got 3 patients on scene. You got yourself as an advanced EMT with your AEMT partner. 3 patients, all unconscious. Is that an MCI?
Yes.
Yeah, but there's only 3 patients. Only 3 patients. Why is that an MCI?
It's more people than responders.
Because you as an AEMT, like you just said, cannot handle what's going on with the resources you have. Okay? You can't handle 3 status 1 patients with 2 AEMTs. I don't care if you're double medic, you can't handle 3 status 1 patients. That is an MCI. You strapped out your resources and there's still patients there. Now you have to triage your patients, okay, of where we're going to go from there until more help arrives. 3 patients.
You also
strapped
can't
and
transport them as well because you can't transport multiple people.
Exactly. You've strapped your system for resources with 3 patients. School bus accident, vehicle off the road, 20 patients or 20 students on board, minor injuries, 1 ambulance. Is that an MCI?
Yes.
Yeah. To start, go in, you triage, everybody's in green, right? 3 patients, fender bender, 1 ambulance. MCI or not?
Yep.
Probably not. 3 patients walking around, no injuries. You can handle that with 2 people, right? So probably not going to be. Talk to your patients, do your assessment, right? The triage process of sorting patients based on the severity of their conditions helps allocate personnel, equipment, and resources to provide the most effective care to everybody. Consider additional or specialized resources by requesting paramedic backup for patients with severe injuries or complex medical conditions. Air medical support. We love it up where we are because our closest trauma centers are so far away. But down in the city, your trauma centers around every corner, right? Know your area, what you have for resources. Remember, air medical transport can bring blood products, okay? We can give all the fluid we want, right? Our isotonic solutions that we carry. All we're gonna do is turn that blood into Kool-Aid. What they need is packed red blood cells, blood. They need that infusion. Fire departments usually provide services beyond fire suppression. So they may have specialized equipment or gear for tech rescue, vehicle extrication, high and low angle, hazmat, swift water rescue, fire suppression. They do a lot of different things where if you're just doing EMS on an ambulance, you don't carry that extra equipment. Search and rescue teams can help find, package, and transport patients over long distances and across uneven terrain. We're in that kind of area up here where we have search and rescue teams going in to get patients on a mountain 4 miles in because they rolled their ankle. I'm not walking 4 miles in. They can bring a patient to me. That's why we have specialized teams. Law enforcement personnel may be needed to control traffic, right? Or intervene with potentially violent patients. So stage yourself in the vehicle in a safe distance until help has arrived to assist you. Ask yourself, how many patients are present? 1, 2, 3, 4, 25, 75. How many? Does the scene pose a threat to you, your patient, or others? It is never wrong to call for backup, even if the extra units are instructed to turn back. If you're running an advanced truck and you've got a patient that is complaining of chest pain, you're responding, feels like their last heart attack, pale diaphoretic, ashen gray color, get the medic started. If you get there and it's not the picture they painted, you can always cancel them, right? But get them coming. Looking at our primary survey, the goal of the primary survey is to identify and initiate treatment of immediate or imminent life threats. Physical exam of the patient to assess for level of consciousness, airway, breathing, circulation, disability, and exposures, ABCDEs, LOC. Primary survey is not an in-depth physical exam, nor an assessment of vitals. It's just your primary survey. Always give priority life threats, right? If you have an airway issue and they have an arterial bleed, do we fix the airway or do we stop the bleed?
Stop the bleed?
Stop the bleed. I get it. They don't have an airway. But if they bleed out, they're dead. So let's be quick about it. Put on the tourniquet, stop the bleed, fix their airway. We've been so ingrained in patient assessment to do airway, breathing, circulation, bleeding. But if they bleed out and all we're fixing is the airway, they're going to die. Stop the bleed. Go back to the airway. right? Perfect, perfect, perfect. Form a general impression. Focus a rapid identification of potentially life-threatening problems. This is the first part of the primary survey. Determines the priority of the emergency medical care. Note things such as person's age, sex, weight, level of distress, overall appearance, and the presence of any obvious bleeding. Overall visual assessment that helps you gather information as you approach, the patient. So note the patient's position and whether the patient is moving or still. Why would that be important? Note if they're moving or still. And you guys, I know you guys, when I'm teaching
Well,
these classes,
if they're moving, they're definitely alive.
Yep. But I know you guys like scenarios, right? So let me paint one for you. Whoever wants to answer it can. 19-year-old female, okay? 19-year-old female. Multiple syncopal episodes, hyperventilating, anxious, chest pain. What goes through your head?
Anxiety attack?
Panic
Okay.
attack.
Yeah, panic attack, anxiety attack. Anybody else want to try it? All right, I got Tandra saying pregnancy. Keep going.
Respiratory distress.
Okay, elaborate.
The anxiety, difficulty breathing, shortness of breath, being put in distress.
Okay, but go a little more in depth. What would cause the respiratory distress?
The way that she was breathing, you described she was breathing.
Okay, Matt O'Connor, you got it right. Ask questions, right? Are you on birth control? 19-year-old female. If you're on birth control, what can that cause? Clotting.
Clots.
Clots gets into the lungs. What's that called?
Embolism.
The clot.
Pulmonary embolism?
Pulmonary embolism. 19-year-old female, anxious, restless, syncopal episodes, hyperventilating, chest pain. Right? We have to look past the obvious of anxiety and look more of a pulmonary embolus. Right? Don't let the fact that she's 19 years old and hyperventilating fool you. Birth
Did you
control,
get a blood pressure on her yet?
not yet, but I got to start thinking more than just anxiety. Right? Anxiety doesn't bring on that chest pain. Right? It doesn't bring on that shortness of breath. It doesn't bring on that multiple syncopal episodes. Okay? So we got to look beyond that. Okay? That's what people usually miss. People usually think it's anxiety. If you're not wrong, still think about it, but don't put past the PE. Don't rule that out yet. What is one thing that we can do in the field? One thing, there's multiple things out there that we can do to help come up with a diagnosis of a pulmonary embolus. Okay, we got Matt saying check lung sounds.
Look for JVD?
Not JVD. Keep going though. What can we do as a tool? What do we have as a tool to help us?
End title.
End title. Okay. Now let's go a little more on that. Would it be high or low?
Low.
Low end title. Exactly. So if you have a patient that's in the back of the ambulance with anxiety, and she's a 19, it could be a 25, it could be a 50-year-old, right? You put them on end title, okay? And the end title is reading 35 to 40. And all of a sudden, it starts developing chest pain, shortness of breath, very restless, okay? And they have a significant drop in end title. Start thinking pulmonary embolus. That's probably what it's going to end up being. This is a patient that you need to move to the hospital. They need a liter of bolus of diesel and get them to the hospital. Nowadays, gasoline. But that's what's happening. Go above and beyond with your assessment. Don't just look at the obvious. Look at everything. Okay? Differential diagnosis. Right? We're not EMTs anymore. We're ALS providers. Right? We're learning. Perfect. All right. If the patient is responsive, introduce yourself and ask about the chief complaint. What is going on today? The patient's response can provide an insight on the level of consciousness, airway patency, respiratory status, overall circulatory status before you even begin your exam. Treat life-threatening conditions. If bleeding out, stop it. If they're not breathing well, fix it. Right? If they're breathing too fast, help them with that. Ventilate if you need to. Coach them. Counsel them and do this. Was the patient injured? If so, what was the mechanism of injury? Does the patient seem to be coherent and able to answer questions? If not, are they altered? And why are they altered? Now do a stroke assessment, right? Now I'm talking just about Cincinnati. Do a fast CD. Do a Cincinnati on top of that. Look at everything. If you want to look super smart, do an NIH stroke scale, right? Does the patient seem coherent? Find out. Determine whether the patient's condition is stable, potentially unstable, or unstable. Where are we sitting with this, right? Constantly be aware of changes in the patient's condition. Maintain a high index of suspicion and begin treatment if the patient or the primary problem appears to be traumatic. Be alert for a possibility of a medical origin. Ascertain gross LOC by determining which of the following three categories that best fits your patient. Are they unresponsive? Are they responsive with an altered level of consciousness? Are they responsive with an unaltered level of consciousness? Where are they sitting? Right? It's almost like your old AVPU scale. Sustained unresponsiveness indicates a critical respiratory, circulatory, or central nervous system problem. Package the patient, provide rapid transport to the hospital. Further assessment will be required for any patient with an altered LOC. So altered LOC in a responsive patient may indicate inadequate perfusion or oxygenation are adversely affecting the brain and its ability to function. It can also be caused by medications, drugs, alcohol poisoning, hypoglycemia, chemical imbalances, and/or a neurological condition. So how do we know if a patient's perfusing appropriately? How do we know if a patient's perfusing?
If they're able to answer, if they're able to answer basic questions that you ask.
Okay, and they answer questions completely off, like it's 1922 for President Reagan. Okay, now we know they're altered, right? And you got to take that to the next step, George, as well. Are they altered times 4, times 3, times 2, or times 1? Right? That's important assessment information. Person, place, time, and event. And which ones are they getting wrong? And then document that in your narrative. And then go as far as your Glasgow Coma Scale, GCS score. Is it 15, 14, 13, 12, 11, 10, down to 3? Okay? Go the next step. If they're altered, how do we know they're not perfusing now? What else can we do?
Circulation.
Okay? How do we check circulation?
Skin color, cap refill, moisture, temperature.
Okay. Awesome. What else can we do?
Radial and pedal pulses.
Okay? Check a radial pulse and their heart rate is 130. What else?
I mean, just have a simple conversation. I mean, you'll know if they're alert or not. They can talk to you. They know what's going on. They can actually speak, complete full sentences, tell you, you know what I mean, why they called you. That's That answers a bunch of questions right there.
You're right, but here's the thing though. Okay, they're altered. We already established that, right? They're already altered. How about vital signs? Blood pressure, MAP, SPO, my country, SPO2, perfect, right? End title. Is the patient being perfused? If the MAP is 55, is that bad?
Yes.
Yeah. Where should our MAP be sitting? Greater than what?
35 to 45.
No, that's end title. That's your normal range for
70, 80 is the map, right?
Nope. Keep going low.
94 to 92.
Nah, 100 then. No,
Uh-huh.
that's
We want to look at greater than 64. Mean arterial pressure. The difference between your systolic and diastolic, mean pressure between the two. Okay. That has to be above MAT 65. So above 64. And that's also a sepsis indicator of less than 64 and they're not perfusing appropriately. If our body's not perfusing, what's going to happen?
Cells are going to die.
Yeah, keep it simple. Shock. Okay, shock. And if shock happens, what happens to the kidneys? They shut down. If the kidneys shut down, now you're in acute kidney injury, acute renal failure. Now our body can't filtrate. Then our organs start shutting down. Multiple organ dysfunction syndrome, MODS. Okay, all this stuff kicks in now. This is the advanced level assessment. We got to fix stuff right away. We got to find out why they're not perfusing and fix it. Is it because they're hypovolemic? Is it because they're hypoxic? Why are they like that? Is it because they're hypercarbic? Do we have to ventilate better for them to bring their end tidal down? There's so many different things we can utilize. Again, it can be caused by medications, drug, alcohol, poisoning, hypoglycemia, chemical imbalance, right? Neurologic conditions. Is it a stroke causing this? And if it is a stroke, where in the brain is it actually causing a respiratory depression, causing the hypoxia? Do they need an airway? Do they need oxygen? Right? I'm throwing a lot of stuff at you guys, but this is what we need. This is where we need to go. And I know deep down inside, all of you have this information. This is where you guys need to start having that verbal diarrhea. Let it out.
When you say chemical imbalances, what types are we looking for?
Perfect. Great question. So with a chemical imbalance, what are we looking for? Number one, carbon dioxide levels. Is it high or low, causing the pH to go up or the pH to go down in the system? Okay. The next one would be, are they hyper or hypokalemic? Right? So high or low potassium. Right? Do they have hyper or hypocalcemia? So high or low calcium. Right? What about sodium levels? Right? So we look at all these different things. Can we test these in the field? No. But are they on medications causing them to reduce their potassium, reduce their sodium? Right? Increase their sodium. If a patient is taking furosemide or Lasix, what kind of medication is that? And we covered this during pharmacology.
The diuretic, they tend to fill with fluid.
Not just a diuretic, what specific type of diuretic?
The CH.
It's a loop diuretic, okay, which then stimulates the ascending loop, causing us to urinate, but also is a non-potassium sparing diuretic causing low potassium. Our labs are going to start becoming off if someone overdoses on it. So we have a medication that caused the chemical imbalance, which then in turn caused the altered level of consciousness. Now we know what we're looking at potentially, right? If I got a patient who overdoses on beta blockers, what am I going to expect?
Low heart rate?
Yeah. And if your heart rate is too low, let's say in the 40s, are you perfusing?
No.
No.
Because your heart's not pumping fast enough. So your body's not going to be perfused. Okay? So give me a beta blocker. Give me a medication that's a beta blocker.
Lisinopril?
Nope. That ends in PRIL. That would be an ACE inhibitor. So Kobe, so Mike, correct, metoprolol, propranolol. So Kobe, albuterol is a sympathomimetic. That's for respiratory bronchodilation. All right. Anything that ends, you have the OL part, but it's anything that ends in OL would be considered a beta blocker that would also reduce heart rate, reduce blood pressure. Right. Now we're thinking like advanced EMTs. Medication list. Did you potentially overdose causing this? And now I'm seeing an altered level of consciousness because now we're not perfusing. Do we need to fix it? How do you fix a beta blocker overdose? Call for a paramedic because they have the antidote for that, which is called glucagon IV. You can give glucagon as an AEMT, but only for diabetic emergency, not for beta blocker overdose. Right? So again, take it to that next level. Test for responsiveness, the way in which a patient responds to external stimuli using verbal, tactile, and painful stimulation. Right? Are they orientated? Person, place, time, event. Right? Alert and oriented times 4, 3, 2, or 1. And if it's a 2, what are they alert to? Is it person and place? Is it time and event? All 4, all 3, or just 1, or none of them? Ensure the patient's cervical spine is manually stabilized by either you or another provider if there is any indication to establish spinal motion restriction. Indicators of spinal motion restriction include the following, right? Blunt trauma with any of the following findings. An MOI that indicates potential for spinal injury, pain or tenderness on palpation of the neck or spine, patient reports pain in the neck or back, paralysis, neurologic complaint, numbness, tingling, partial paralysis of the legs or arms. In male patients, priapism, altered mental status, intoxication on drugs or alcohol, a Glasgow Coma score of less than 14. For those of you who do not have Glasgow Coma score memorized, you need to do that. You have to memorize the GCS score. That is a medical assessment and a trauma assessment, and your bigger hospitals want that information. And also, I want to see it in your documentation. Distracting injuries, injuries to another body part that potentially make the other patient's report of neck or spinal pain be unreliable. Like a femur fracture is going to trump the pain for someone who has neck or back pain. Difficulty of the inability to communicate. Utilizing our AVPU scale to test the responsiveness based on the following criteria. Are they awake and alert, response to verbal stimuli, response to painful or pressure, or unresponsive? We have to make that check. So this figure here shows the appropriate methods of gauging a patient's responsiveness to pressure stimuli. Gently but firmly pinch the patient's earlobe. Press on the bone above the eye. Keep in mind, if they got raccoon eyes, don't push on that side. All right. Gently but firmly pinch the muscles of the neck. That's what they call a trapezius. Well, even a little farther here. If you can see my arrow on the screen, if you pinch down here, it's called a trapezius pinch. That'll drop a big guy to the ground. All right. So again, this works. Pinching over here. Determine whether the patient who does not respond to verbal stimuli will respond to pressure. All right. So uncomfortable stimuli, gently and but firmly pinch the patient's skin. We talked about that. Earlobe, triceps, trapezius area. Rub your knuckles on the patient's sternum. Provide an upward pressure along the orbital rim, or try to elicit a response on the other side of the patient if the patient does not respond on one side. Could it be the fact they're having a massive stroke? Could it be a spinal injury causing paralysis on one side and then they have no feeling? So check both sides. All right, we'll finish up the airway stuff here and then we'll take a 10-minute break. So we're going to assess the airway. Always be alert for signs of the airway obstruction. Mild or severe airway obstruction will result in inadequate or absent airflow into and out of the lungs and inadequate perfusion of the entire body. So determine if the airway is open, patent, or inadequate. Continuously reassess the airway all the time, right? We do not want them vomiting. Vomiting is bad. Let's control it. Give them Zofran, okay, if they are allowed to get it. Responsive patients, patients who are talking or crying or moving air. Watching and listening how patients speak may also provide important clues about the adequacy of the patient's of their airway and the status of their breathing. A responsive patient who cannot speak or cry is most likely has a severe airway obstruction. We got to find out why and where it is. Stop the assessment process if an airway problem is detected and work to clear the patient's airway. Again, if they're bleeding out, stop the bleeding. Signs and symptoms of the airway and breathing problems often overlap. Check lung sounds. Unresponsive patients immediately assess the patency of the airway. It's open, let's keep it open. It's not open, let's open it up. Unresponsive patients should be considered to have experienced a traumatic event. Kind of keep that in the back of your head. So again, if you think it's trauma, jaw thrust maneuver, head tilt chin lift. If it's not a traumatic event, another cause of airway obstruction in an unresponsive patient could be relaxation of tongue muscles. So do they have a gag reflex or not? Do we need to put an OPA and NPA in to be able to help them oxygenate? Right? There's nothing wrong with putting an OPA in place and putting them on a non-rebreather, right? If they're ventilating appropriately. Dentures, blood clots, vomitus, mucus, food, and other foreign objects may also create an airway obstruction. So if it's blocked, clear it. Clear it with manual techniques or suction. Signs of airway obstruction in unresponsive patient include obvious trauma, blood, or other obstructions that are there. Noisy breathing, such as snoring, bubbling, and or other abnormal sounds. So extremely shallow or absent breathing. Again, if they're not breathing well, if they're breathing too fast, too slow, too shallow, we need to make that assist, and that's utilizing a BVM. For patients with patients with unknown illnesses, manually stabilize the cervical spine using a jaw thrust maneuver and open up that airway. Let's see if we can then reposition. All right, let's take 10 minutes. We'll come back at 7:20 and we'll continue on.
This conference will now be recorded.
Lose somebody. All right, so let's talk about assessing breathing. So after you have made sure the patient's airway is open, we need to ensure that breathing is adequate, right? So is it labored? Is it too fast? Is it too slow? What is the patient's breathing status like? So there are three things we look for in every assessment, right? Whether it be pulse, respiratory rate, okay, is rate, rhythm, and quality of that specific assessment. So what's the rate of the breathing? What is the quality like? Is it tachypnic? Is it too slow, too fast, irregular, right? So we look at all those different things from Kussmaul's breathing for patients in diabetic ketoacidosis. A lot of things can be told just by looking at the breathing, right? So a patient who's breathing without assistance is said to have a spontaneous respirations and spontaneous breathing. So we ask the following questions. Does the patient appear to be choking? Yes or no? Is the respiratory rate too fast, too slow? Is the respirations shallow or deep? Is the patient cyanotic? Do you hear abnormal breath sounds when listening to the lungs? Is the patient moving air into and out of the lungs? Inspiration, expiration, in and out. Are we perfusing our system? Without a good respiratory system, we cannot perfuse our body, right? So we're going to rapidly assess respirations to determine if the rate is normal, fast or slow, shallow or deep, or is it normal? Is their chest rise equal or unequal? What would happen, what would it be if a chest rise was unequal and you heard absent lung sounds on one side? What could that be?
Collapsed lung.
Yeah, exactly. Collapsed lung, pneumothorax. What's causing that, right? Paradoxical chest rise, okay? Like Rosa mentioned, broken ribs. Is there a flail segment? You know, we got to do that assessment, hands on. Spread your fingers, go underneath the breast. Okay, please do not grab underneath. Lift, wrap your hands around. Have a take a deep breath. Feel for equal rise and fall. Assess the patient's breathing and listening to breath sounds using a stethoscope over each lung. Right, each lung. How many lobes are there on the right side? How many lobes do we have on the right, and how many lobes do we have on the left? Right, 3 versus 2, exactly. Right, so listen to every lobe. Right, utilizing a Z pattern going down the back. Right, you should be listening in 6 different locations in the back and 4 more locations in the front. Right, we're going to assess the respiratory breathing and obtain the rate, the quality and character of breathing, the degree of distress, looking at word dyspnea, use of accessory muscles in the chest or the neck. If a patient states they're having difficulty breathing, never withhold oxygen, even if the pulse oximetry reading is reading 100%. Okay, because it could be a false reading. Give me 2 indications where you would have a false pulse oximeter reading. Where it would read 100%. Okay, so you have nail polish and cold hands. Let's talk about another condition within the system itself. Carbon monoxide being one. What's the other one?
COPD.
Well, yeah, COPD would cause the low SpO2, but if it was reading 100%? If your pulse ox, COPD is correct though. If you have a patient with low pulse oximetry, it could easily cause that. What if they had 100% reading? Carbon monoxide is one of the bigger ones in patients that are anemic. Can also give you a false reading as well. So provide positive pressure ventilations for patients who are apneic or whose breathing is too slow, too fast, or too shallow because they need that assistance. If they're going too fast, if they're going too slow, they got to bring back that homeostasis, right? We got to meet that level, reduce that hypoxia, less cells for the hemoglobin to stick to. Exactly, right? And we're going to get false readings. Exactly, Mike. Where was I going with this one here? What's another way to tell if they're perfusing again? What else can we monitor? Okay, MAP is one thing we can monitor. What else can we do though? End tidal, right? End tidal CO2, basic level skill in New Hampshire, all the way up to paramedic level. If a patient is breathing too slow, would you expect to see end tidal high or low?
High.
High. Perfect. 100% correct. You would see it high. If they're breathing too fast, high or low?
Low.
Opposite. The opposite of what I just told you, right? So high and low. And how do we fix that? Not oxygen, rate. And how do we fix the rate?
CPAP.
Coaching, CPAP, BVM, bagging, like Mike just said. Perfect. Right, we're on the right track. We're thinking like ALS providers, right? But the next step of ALS thinking is, now that we fixed this on a cellular level, what are we doing? And that's where I want you guys to start going with this. We don't do a procedure because the book tells us to do it. We do a procedure because this is the cause, this is the effect, and this is how you fix people utilizing the pathophysiology behind it. That's the mentality I want you guys to think about every time you have a patient contact. If I do this, this is going to happen, and this is why. Because you're going to give medications to assist in that process. And understanding pathophysiology is going to help you tremendously. The goal for oxygenation for most patients is an oxygen saturation level of 94 to 99%. If a patient develops difficulty breathing after your primary survey, immediately reevaluate the airway. Things can change. Air exchange is the critical issue, not simply the number of breaths, but how air is exchanged. That's why we have to monitor end tidal. End tidal is the here, the now, right? What's going on currently with that patient's respiratory drive. Pulse oximetry has a delay. Yes, they work hand in hand. They measure two different things, but I want to know inspiration, expiration, are they perfusing, and then are they getting oxygenated? And if I can make sure we maintain 94 to 99% with an end tidal between 35 and 45 with a rate between 12 and 20, now I've met homeostasis and the patient's not going to be hypoxic. Does that make sense? That's where I want to get this patient. Okay, we have the tools. Let's utilize them. From drugs to devices, we can do it. All right. Observe how much effort is required for the patient to breathe. In the next picture, the next slide I'm going to show you guys will be two common postures. Shallow respiration can be identified by little movement of the chest or poor chest movement itself or excursion. Deep respirations cause a significant rise and fall of the chest. So we're going to document the patient's respiration and are they shallow or deep. Labored breathing is characterized by the patient's position, concentration of breathing, and increased effort and depth of each breath. So signs of inadequate breathing would be presence of retractions, nasal flaring, seesaw breathing, supraclavicular and intercostal retractions in pediatric patients, or patients who can only speak 2 or 3 words without pausing to take a breath. This is what we call the 2 to 3 word dyspnea. These are all things you need to document in your narrative as well. Here are the 2 common positions. The first one you see is the tripod sniffing type tripod position, and you see the sniffing position on the side over here, on the left-hand side. Then we're going to start assessing circulation. So again, in pediatrics, we're going to look at checking a brachial pulse. So this helps you evaluate how well the blood is circulating to the major organs. Are we getting good, strong pulses? Circulation is evaluated by assessing the patient's mental status, pulse, and skin condition, right? So if the patient is altered with a heart rate of 150 and they're pale, clammy, and diaphoretic, are they perfusing?
No?
No, they're not.
No.
You can tell because now they're in what they call compensated shock. They're pale, they're diaphoretic, they're tachycardic. And if I said the respiratory rate was 35 to 40, right? Those are signs and symptoms of compensated shock, right? Not a breathing issue, probably a hypovolemic issue. Why is it high? What's causing them to be like that, right? Could it be a distributive type of shock or an obstructive type of shock? But the patient has inadequate state of tissue perfusion causing this to happen, right? We're going to assess the pulse, and the pulse is the pressure wave that occurs in each ventricular contraction. When you feel a pulse, that is the patient's QRS wave on an EKG, right? That's your ventricles depolarizing, right? Which we'll cover more of that in cardiology. Most easily felt at a pulse point where a major artery lies near the surface. In a responsive patient older than 1 year old, you want to palpate the radial pulse at the wrist. In a unresponsive patient older than 1 year, palpate the carotid pulse in the neck, right? When you palpate a pulse, do not use your thumb. Remember, your thumb contains a pulse as well. And your normal heart rate for an adult is 60 to 100 beats per minute, which amazingly enough is your intrinsic rate of your SA node of your heart, 60 to 100. We want to, during the primary survey, we want to assess the pulse to determine if it is present or absent, normal, fast, or slow, weak and thready, or strong and bounding. Determine the adequacy of the pulse during the secondary assessment as well. Always reassess to see if there's any changes. Rate, rhythm, quality. If you cannot palpate a pulse in an unresponsive patient, begin CPR. You're better off doing CPR in a patient that has a pulse than withholding CPR in someone who does not. That is basic level stuff. If the patient has a pulse but is not breathing, Provide ventilation at a rate of 10 to 12 breaths per minute for adults and 12 to 20 breaths per minute for an infant and a child. If at any time the pulse is lost, start CPR and apply an AED. Never begin CPR using AED on a responsive patient. They're not going to be too happy with you sticking something in the chest and saying stand clear. All right, they may not like that too much. We're then going to assess the skin. Skin can tell you so much information, right? Whether it be allergic reaction to being late signs of carbon monoxide poisoning, late signs, to perfusion levels. I mean, there's so many things that the skin can tell you. So looking at circulation, perfusion, blood oxygen level, if they're cyanotic, are they hypoxic, and body temperatures, right? Are they cold? Are they warm? Are they flushed? Right? Skin color. Look at the skin to determine if the blood is circulating through the vessels and the amount and type of pigment present in the skin. Blood is red when adequately saturated with oxygen, and the skin is lightly pigmented. And lightly pigmented people is pink, right? So what if you're African American? How do we check that? I have to ask that question, right? How do we check it? How do you know they're perfusing? Looking at skin color and temperature. What are we looking for? I see conjunctiva or oral mucosa, the mucous membranes, behind the eyelids, behind the lips, right? Nail beds. We have to look at all these different aspects. Fingernail beds, mucus, lips, the underside of the arms, palms, conjunctiva of the eyes. Other ways we can check circulation, right? Making sure we're being perfused. Assess the palms of the hands and the soles of the feet in infants and children. Inadequate peripheral circulation will cause the skin to appear pale, white, ashen, or gray, or possibly even waxy, translucent appearance. Cyanosis is skin over the blood vessels appear to be blue or gray, which are signs of low oxygen in the blood. Most likely going to be seen, especially when you see the pediatric first, we start seeing around the lips, around the mouth. High blood pressure may cause the skin to be abnormally flushed and red. So if you swim up and see someone flushed and red, could it be a hypertensive crisis? What happens if it is? What are some things we need to watch out for in a hypertensive crisis? Give me one big one. $300 over 220 for a blood pressure. What are we concerned about? Yeah, AAA. What else?
Cardiac issue?
And strokes, right? Might just a TIA or a full-blown vessel popping, right? So we may have a pop vessel in the brain causing a hemorrhagic stroke, brain bleed. Liver disease or dysfunction may also cause jaundice, which is yellowish skin, right? You may also see yellowish of the eyes as well, all part of your assessment. That means their liver is not functioning appropriately. So the skin temperature, is the skin normal skin, warm to, or is it warm to the touch? Or is it hot to the touch, cold to the touch? Normal skin temperatures are hot, cold, cool, cold, and clammy, right? Significant fever, sunburn, or hyperthermia will make the skin feel hot to the touch. Skin will feel cool when patient is in early shock, has mild hypothermia or inadequate perfusion. So how do we check a temperature in these patients?
With the back of your gloved hand.
And we got to get a reading. We need a number. We got to start treating our patients now, right? Quick assessment, back of the gloved hand. Further assessment to start treatment would be.
Thermometer.
And where does the thermometer belong?
In the first in bag.
In the first, I like it. In the first in bag, right? It belongs with a patient, depending on the patient of where we check it, whether it be oral or rectal. Please do not mix those two together, right? Could be axillary in the armpit. It could be as simple as a skin temperature measurement as well, right? Keep in mind that patients that are hypothermic, that are in the back of your ambulance, skin temperature may be different than a true core. If you feel the need that a rectal needs to be done, we do it, okay? Has to be done, depending, like Matt O'Connor said, depending on the patient. I know that it's not within our top priority to take someone, turn them sideways, bend their knees, and stick a thermometer up their butt. It's got to happen. Okay, we got to check our rectal temps, especially in kids, infants, right? That's no oral, rectal thermometers. We carry them on ambulances for a purpose. Let's use them, right? Feel the patient's torso underneath the clothing with the back of your hand. Determine whether the patient's temperature is elevated or decreased. Looking for dry skin. Dry skin is normal. Skin that is wet or moist from sweat or excessively dry or hot suggests a problem, right? So because of the color, temperature, and moisture of the skin are often related signs, consider everything together. When recording or reporting an assessment of the skin, first describe the color, then the temperature, and whether the skin is dry, moist, or wet. Pink, warm, and dry, cool, clammy, diaphoretic, which one is it going to be, right? We have to determine our assessment. If they're pink, warm, and dry, we know that they're perfusing currently. Could things change? Absolutely. Capillary refill time, what they call CRT, which is often evaluated in pediatric patients to assess the ability of the circulatory system to restore blood or perfuse the capillary system in the fingers and toes, which may provide an indication of the pediatric patient's level of perfusion. How fast should a cap refill come back if you press in the fingers? What's our normal time?
2 to 3 seconds.
Right. What if it takes 6 seconds to come back? Is that bad?
Yep.
Yeah. So does that mean that they're perfusing too much or perfusing too little?
Too little.
Right. Now we got to figure out why. What is causing them to be not perfusing? All right. Next slide. So we're going to assess and control external bleeding. If you have external bleeding, control it. Identify it and immediately control any major external bleed. Now, if it's a laceration to the arm, it's a little capillary bleed, is that top priority over someone's airway?
No.
Not at all. Okay, they can live with a little capillary bleed. Now, if they cut the radial artery and it's spurting out, hitting the driver up front driving the ambulance, that's a problem, right? We got to stop that. Okay, by doing so, we need to make sure that we're applying tourniquets. What's another method, another thing we can also utilize to stop that bleed?
Direct pressure?
And we also carry, what else?
Pressure,
Quick clot?
pending, wrapping.
Quick clot. Like who said quick clot? I didn't hear it was.
I didn't.
Perfect. Quick clot. Hemostatic agents. Okay.
Lay down.
Mike, you're thinking too much like a medic. GXA. I love it. I just gave that this morning to a patient. So do a sweep for blood by running your gloved hands from head to toe, pausing periodically to see if your gloves are bloody. This is what they used to call the blood sweep. It was taught in some EMT classes years ago, and I haven't seen it since. But the old blood sweep. It's no different than doing a head to toe assessment. Just look for blood. Jeans can retain blood, right? Expose your patients with trauma. Get them trauma naked. Preferably not on the side of the road, in the back of your trunk. Teach an EMR student, yeah. I haven't taught blood sweeping forever. But EMR, yeah, I taught an EMR class years ago, and we did talk about the blood sweep during the assessment. So when direct pressure is not quickly successful, or whenever you encounter obvious arterial hemorrhage of an extremity, apply a tourniquet. Tourniquet back in the day used to be, oh my God, don't apply this, it's so bad. Now we're doing it first line. If a patient is bleeding out, but also doesn't have an airway, I'm not going to focus on that bleeding for 25 minutes. I'm going to tourniquet, I'm going to stop it, I'm going to move back to the airway, clear it, and fix it and maintain it, right? Stop the bleed. Apparent absence or palpable pulse in a responsive patient is indicative of a low cardiac output state. We need 12 leads on these patients. If you can't feel a pulse on an unresponsive patient, obviously begin CPR. Any patient with impaired circulation should receive high flow oxygen by a non-breathing mask or assisted ventilation. Why is that? Why are we giving them oxygen again?
To help them perfuse.
There you go. Help them perfuse. Awesome. All right. So to perform, when assessing for the patient's disability, perform a brief neurological evaluation of the patient, determine the patient's normal mental status and any deviation from an alert-oriented person, place, time, and event, or from the patient's normal baseline is considered to be altered, right? So some ways of checking for this disability or checking the neurological assessment would be orientation tests that we can perform in the back of the ambulance. Person, place, time, and event are big ones. People should know those specific things. Glasgow Coma Scale, eyes, verbal, motor response. Eyes go from 1 to 4. Verbal is 1 to 5. Motor is 1 to 6. Keep in mind that in the motor assessment on the GCS score, you have decorticate and decerebate posturing. Which one is worse than the other?
Isn't it the corticate?
Decorticate is the boxer stance, and that is actually better than decerebate. Decerebate posturing is arms extended laterally out, and that is actually part of the GCS score of a 2, where decorticate would be a 3. But still, both really bad. Both have significant neurological deficit with those, right? And I've seen decerebate and decorticate posturing in significant strokes or head traumas and TBIs, which is actually pretty bad. A lot of patients don't come from that. And you got to watch out as well for increasing cranial pressure and brainstem herniation with that as well. So really, we need to monitor vital signs, look for hypertension. Is the brainstem going to herniate and cause them to go into cardiac arrest? These patients need to be at a trauma center quickly. Yeah, like I said, bad shit. Exactly. Bad stuff happens. Right? So perform a rapid full body exam. Visually inspect each area to ensure an accurate and thorough assessment. This exam from head to toe should take no more than 60 to 90 seconds. So when we start doing our assessments on that Saturday, on the Sunday class on the 30th, we start going over assessment. I'm going to start timing you guys because you have to get that down and get that down quick. For those of you who want to go to medic school, they will time you and you have to get it done in 60 seconds. So guidelines on how and to what to assess during the rapid full body scan. Inspection, looking at your patient for abnormalities. Okay, look, listen, feel. Okay, palpation, touchy, feely, professional touching and feeling the patient for abnormalities. Auscultation, listen to body sounds using a stethoscope. Yeah, stethoscope is part of your arsenal of equipment you should be utilizing. Decap BTLS, okay? And you monitor to remind you what to look for when you're inspecting or palpating various body regions. What does decap BTLS stand for?
Deformities,
Deformities, contusions,
abrasions,
abrasions, punctures,
ulcers.
penetrations, burns, tenderness, laceration, swelling.
Yeah.
Perfect. I don't know. Love it. Love it. Right? So again, we are going to cover this full body scan, and it has to be quick. It's determined to find life-threatening injuries. Okay? Femur fractures, things like that. Ones that need to be addressed now, or do we pick something up on the rapid that we can go back and fix during a secondary assessment? Identify the other life threats by determining if a life threat is present, and if so, we'll quickly address it. When doing a rapid head to toe, is a pelvic fracture considered life-threatening?
Yes.
Yes.
Absolutely. How much blood can you lose in a pelvic fracture?
A
Average,
shitload.
right? I wouldn't write that in your run report, Jen, though. Right? How much blood can you lose on an average? Give me a number. Three liters on average can fit into your pelvic cavity, right? 3 liters. That's a lot of blood, right? 3 liters is a lot. Okay. A femur fracture, is that considered a life-threatening injury?
Yes.
Yes.
Yeah. How much blood can you lose on average per femur?
2 liters.
Right about 750 mLs to a liter of blood. On average, 750 mLs per femur fracture. How much blood does our body normally have? Regular adult. Everybody should be saying between 5 and 6, right? 5 to 6 liters. If we have 5 liters of blood, more than half our blood supply can go right into our pelvic cavity. It is so important to make sure that you stabilize pelvic fractures on your rapid assessment. So therefore, if it takes longer than 60 seconds, you're stabilizing that severe injury. Pick up on it, okay? In, downward motion, feel for crepitus. If there's significant pain, stabilize it, because it may not be a severed artery at this point in time, but movement of that patient can cause that to happen, right? Same thing with femur fractures. Pull traction, right? Prevent those sharp bones from severing any kind of artery. Recognize other signs and symptoms as well of life threats. Anxiety, okay? Anxiety might not just be the panic attack. It could truly be the fact that they're losing perfusion and they're becoming altered. Sense of impending doom, loss of meaningful communication, loss of consciousness, unresponsive to external stimuli. Muscles become slack, tongue sags in the back of the throat, now blocking or occluding our airway. The most common airway obstruction you're ever going to find is your tongue getting in the way. That's why we have oropharyngeal airways, to displace the tongue back to its normal state so we can actually ventilate patients, and or put on an on-rebreather if they're still breathing fine. They're just unconscious and can't maintain their tongue. Only a few general conditions cause sudden death. Airway obstruction being 1, respiratory arrest being 2, 3, respiratory failure, 4, primary cardiac arrest, 5, shock, 6, severe bleeding. These conditions are often manageable or reversible. You have to be able to recognize them quickly and take immediate steps to correct them, right? We can fix airway obstructions for the most part. Sometimes we just can't get in, right? But 95% of the time, if not more, we can fix an airway obstruction. Can we fix respiratory failure? Can we breathe for somebody? Absolutely. Do we have medications at the A level to help with that? Yes, right? If it's a respiratory arrest, we can breathe for them. As long as we breathe for them, they're getting oxygenated. Therefore, they don't go into cardiac arrest. Primary cardiac arrest, we have AEDs. In New Hampshire, we have Epi 1 to 10,000 cardiac Epi for cardiac arrest management, right? We can treat for shock. We can keep patients warm. We can give them fluids, right? We can use tourniquets. We have quick clot, hemostatic agents. We have the ability to help. Often these conditions are manageable or reversible, but if you have to be able to recognize them quickly and take immediate steps. Identifying and correcting life-threatening issues begins the assessment of the ABCDEs, right? When a patient is in cardiac arrest, assess ABCDEs simultaneously. Remember, AHA says compressions, airway, breathing if they're in cardiac arrest. Controlling life-threatening bleeding takes priority over airway, breathing concerns any day of the week. Wrong button. Oops. Determining the priority of the patient in care and transport. A rapid full body scan will assist you in determining transport priority. Is it a stay and play or a shit and get? Do we need to get this patient out into the ambulance and transport rapidly to a specific hospital? High priority patients should be transported immediately. Difficulty breathing. serious MOI, poor general impression, an alteration in mental status, severe chest pain, pale skin or other signs of poor perfusion, complicated childbirth, like limb presentation, right? Uncontrolled bleeding, responsive but unable to follow commands, neuro issues, severe pain in any area of the body, inability to move any body part, right? So protecting the patient's spine, identifying fractured extremities are integral parts of packaging for transport. Do we need to stabilize? Right? If you suspect a spinal injury or mechanism of injury is significant enough to cause a possible injury, consider spinal motion restriction early. If you have enough of an impact on a motor vehicle accident or whatever it may be, a fall, to break someone's femur, it's enough to be able to have a spinal cord injury. Someone's still unmuted. Kenny, I think you're still unmuted. Right. The golden hour, okay, remember that refers from the time of the injury to definitive care, during which the potential for survival is at best. So we want to spend as little time as possible on scene with patients who have sustained significant or severe trauma. Aim to assess, stabilize, package, and begin transport to an appropriate facility within 10 minutes after arrival on scene. This is what they call the Platinum 10. Right? So some patients may benefit from remaining on scene and receiving continuous emergency medical care. It's based on the provider and what you need to do before you start going for stabilization. Because going in the back of the ambulance doing Mach 100 and trying to get IVs and splints and everything else on board may not be the best. So if you've got to stabilize first, but don't be on scene for hours on end. Right? Call for support from paramedics if a unit is not already en route. Or a paramedic can meet you while transporting, which is considered a paramedic intercept. Correct identification of high priority patients is a essential aspect of the primary survey. Rapid transport is one of the keys of survival of any high priority patient, getting them to definitive care where they have ER, OR, ICU, all this stuff that can be done at that point in time. Reassess the patient vitals every 15 minutes until you reach the emergency department for your stable patients, 5 minutes for your unstable, and look at the MOI again to ensure that you have not missed any important information. Look at your patient, take everything you've gathered from information, your assessment, your interrogation, your vital signs, right? All this information, formulate a plan, and then reassess what you've done. And given this, I expect this to happen. Is that happening? Or do I need to repeat another dose or something to be able to meet that effect I'm looking for? Okay, that's what we're looking for patients. Right? When it comes to history taking, this provides details about the patient's chief complaint and an account of the patient's signs and symptoms. So interrogation, gather as much information as you possibly can from the family, friends, and bystanders, and then get on the road. Right? Check for medical identification tags, paperwork, DNRs, DNIs, DNHs, MOLS forms, living wills, whatever may be out there. Look at what's there in front of you. Right? Do not delay transport for patients who are unstable. Then document all the information that you gather, from demographics to medical history to current health status, pertinent family history, recent travel history. A lot of this information you need to document because it all plays part in your patient assessment. We're going to investigate the chief complaint. So begin by making introductions and making the patient comfortable. They are inviting you into their home or into their lives at their worst time. Professional is key for these patients, okay? Remember, they called you for help, so don't go in there stereotyping them, okay? Ask few simple, open-ended questions. Open-ended, but simple. Keep it to the task. If you have an elderly patient, you say, all right, would you have any chest pain, shortness, but dizziness, nausea, vomiting, diarrhea, blurry vision, headache? They're not going to have any clue what they're saying yes to. So one question at a time. Do you have any chest pain? No. Any shortness of breath? No. Any difficulty breathing? Are you no. You know, and do you have a headache? Yes. Right. The KISS concept. Keep it simple. Right. Do not interrupt and be empathetic of the situation. Eye contact, body position, and language to encourage the patient. Get down to their level. Don't stand above them. Get to their eye level and address them appropriately. Mr., Mrs. Let's say, okay, please call me Jim. Okay, Jim, my name is Kevin. You know, what is going on today? Well, let me explain it. Okay, do you have any allergies to medications? Do you have any medical history? Any past medical history at all? Well, I had my knee operated on back in 1932. Okay, anything like this? Do you have any cardiac history? Do you have any respiratory conditions like COPD, asthma, bronchitis, or emphysema? You know, keep it tailored to what you're asking for. And use family members and friends, bystanders, and other public safety personnel, and utilize them to assist you with question taking. Investigate the history of present illness utilizing OPQ or ST, right, which most of us we all should already know. When did it start? When did the problem begin? Provocation. What makes it better? What makes it worse? Anything that brings relief to the pain. Abdominal pain, right? Does it get better with your knees bent or laying on your side? If so, can we do that? Is that we have that ability? Looking at the quality, the patient's description of the pain, avoid asking leading questions. Have patience. Don't lead them into something, right? Carefully document the patient's own words and ask the patient to point the area of pain. Let me know where it hurts. Describe areas of pain or pain where anywhere else associated with that, focal or diffuse pain, right? Do I have pain in my abdomen and also pain on my left shoulder, right? Do we have a splenic injury? Do we have referred pain, radiating pain? Document. Radiating pain refers to an area of the body from which the origin of pain or discomfort may travel. Referred pain is pain that exists in more than one place. Again, like a splenic injury, which would cause shoulder pain. The patient's perception of how bad the current incident is a comparison with others. And ask the following questions. How bad is the episode in comparison with previous ones? What happened the last time you had an episode this bad? How would you rate the problem in numbers? If 0 is normal and 10 is the worst pain you've ever had, how would you rate your pain currently? You can also use that same 0 to 10 in breathing condition as well. And then timing, or T, or questions related to time, provide information about when the problem began. Has it been going on for 5 hours, 6 hours, 7 hours? Did it come on all of a sudden? Onset and timing. Interventions, where some patients may self-treat or self-medicate before calling 911. One of the biggest ones we come in contact with are medicating with aspirin for chest pains. By EMD, they tell them to take 324 aspirin, right? And they may have already taken some of their own personal nitro. Or allergic reaction, and they took their own EpiPen. Identify pertinent negatives, findings you would expect based on the patient's complaint, but that are not currently present. So by asking them, do you have any chest pain, and then saying no is a pertinent negative. We're then going to investigate the past medical history using sample, last oral, so signs and symptoms, medications, or allergies medications, pertinent past medical history, last oral intake, and in female's case, last menstrual cycle, and events leading up to the illness or injury. Obtaining history on sensitive topics, you may have to separate them from whoever they're with to be able to get the true information. So signs and symptoms while under the influence of alcohol or drugs may be confusing, hidden, or disguised. The patients may also deny the use of drugs or alcohol as well, especially when they're in front of other people, including law enforcement. So when you get them alone, ask them again. They might give you a truthful answer. I'm not a cop. I just want to make sure I give you the right medication so that way it doesn't kill you. History that you gather from the patient with a chemical dependency may be unreliable. Imagine that. So establish a strong rapport with your patient, right? Let them trust you so you get the appropriate information. Impress on the patient that the information received will be kept in confidence, right? They have that right under HIPAA. Physical or abuse or violence, we want to report all suspected physical abuse or violence cases. If you suspect a patient is a survivor of physical abuse or domestic violence, immediately involve law enforcement. Look for hidden clues. Imagine that, there's a clue, that such a situation does exist. We're going to note whether the information provided by the patient and others present at the scene is inconsistent. So we want to look for a consistency of what we're talking about in questioning that we're asking, right? Physical aggressors may also be present in answering questions as well. Therefore, you may get, oh, I'm fine. In all reality, they are not. Get people separated, and you have a better chance of getting the right information. High index of suspicion is also very important as well. Remember to be non-judgmental, right? Don't judge anybody. It's not our place. Right. Accurate, thorough, and objective documentation is also very important in cases of abuse or domestic violence. We want to look at their sexual history. Most patients find sharing information regarding their sexual history is very uncomfortable. So consider all female patients of childbearing age who report lower abdominal pain to be pregnant unless ruled out by history or other information. Questions to ask would be the last menstrual period. Are your periods normal, heavy, light? Are there any vaginal discharge or bleeding present that is not associated with your menstrual period? Anything different? Do you have urinary frequency or burning, potentially for UTI? What is your severity of cramping? Are there any unpleasant odors present? Is it possible that you may be pregnant? Are you taking birth control pills or using other types of birth control? How many sexual partners do you have? Have you had any recent sexual encounters? Right? When dealing with a male patient, inquire about urinary symptoms as well. Do you have any pain associated with urination? Do you have any discharge, sores, or increase in urination? Do you have any burning or difficulty voiding? Any trauma? How many sexual partners do you have? Any recent sexual encounters? Ask about the potential for sexually transmitted diseases. Remember that all information we have is considered confidential. It is only going to be passed on to other people that are directly involved with your patient care. Some special challenges in obtaining a patient history would be silence, so be patient. Use closed-ended questions that require a simple yes or no answer. Consider whether the silence is a clue of the patient's chief complaint. Look for visual signs of patient environment that may indicate why a patient is not communicating. Look for the nonverbal clues as well as facial expressions that may show pain or fear. Overly talkative patients, possible causes would include excessive caffeine consumption, nervousness or ingestion of a cocaine or methamphetamine. Allow the patient a chance to talk. Do not interrupt them. Allow them to have a chance to speak. Right? Direct all patients to stick to the facts by summarizing statements frequently. Clarify the statements for the purpose of making sure information you are gathering is correct. If they have multiple symptoms, spend extra time assessing the patient. Okay, they could have chest pain with abdominal pain, lower back pain, knee pain, leg pains. Spend some time, talk with them. Unless they're unstable, we have a moment. Prioritize patients' complaints as you would during triage. Because they're having foot pain because they have gout, I'm not going to put more time and effort into that until I get the chest pain that they also stated under control. Always ask for additional information to determine why EMS was called. So keep an open mind and do not focus on one complaint or detail. Look at everything, right? Differential diagnosis. Anxious patients may also be observed in emergency scenes that involve a large number of patients. Can also be encountered during routine EMS call when the family members or patients cannot cope with what's going on. Expect anxious patients to exhibit signs of psychological shock. So anxiety may also indicate low blood glucose level, shock, or hypoxia, right? So PEs can cause anxiety as well, causing severe hypoxia. Reassure the patient that any nervous or anxious response is normal and can be overcome. This is where we start coaching our patients to breathe better and calm down. Right? Reassure the patient that any nervous or anxious response is normal and can be overcome. Always be observant as well. Be aware of nonverbal clues such as posture, position, and facial expressions. Look at that body language that they're providing, right? Is it safe to be there? If they're intoxicated, please be aware of the information may not only be difficult to get, but also can be unreliable. Patients may become impatient with you when trying to provide you with the information if they're intoxicated. Do not put patients in a position where they feel threatened or have no way out. Sit there, same level, have the conversation with them. Allow them to speak, allow them to know that they have rights. We just need to talk about it. Being accepting, diplomatic, objective, and non-judgmental will get you so much farther than walking in, stereotyping them, yelling at them, telling them that they're a piece of crap because all they do is use drugs all the time, and they should go die somewhere out in a river, right? Probably shouldn't be saying that to your patient, right? Be respectful. Crying, a patient may be sad, in pain, or emotionally overwhelmed. Again, it could be anything on why they're crying. Remain calm, be empathetic, sympathetic, and respect the patient's dignity. If they have depression, remember this is one of the leading causes of disability worldwide is depression. The symptoms include sadness, a feeling of hopelessness, restlessness, and irritability. So be non-judgmental, compassionate, right, to these patients. Often the patient just needs someone to talk to or someone to listen. If you can be that person to listen, you'll get a lot farther with them during your transport to the hospital versus not listening and just being a dictator on what's going to happen. Confusing behavior or history, be aware of medical causes that lead to this. Hypoxia, stroke, diabetes, trauma, and drug or medication use. So one of the most common causes of confusion is hypoxia. Why are they low oxygen? Older patients may have dementia, delirium, or Alzheimer's disease as well. So verify the baseline mental status of each patient. If the patient is confused, remember this is not a normal response. We got to find out why. Do our stroke assessments, check our blood sugars, find out why the patient is confused. End tidal can also cause that as well. So confused behavior, remember it's not normal. We have limited cognitive abilities, so keep the questions simple and limit the use of medical terms. Keep things simple, like Tandra had mentioned earlier. For patients with severely limited cognitive function, rely on the family, caregivers, and friends to supply supplemental answers. And last one here, and we'll take another break. It's been another hour. Language barriers, also consider to use interpreters, translation resources, related mobile device apps. Apple has a translator now on their phone. You can utilize that by typing stuff in and having it repeat it in any language you need to repeat it in. Determine whether the patient speaks or understands any English. Now, if you're multilingual, perfect. I like it. Determine whether the patient understands who you are. I am Kevin. I'm a paramedic here with the ambulance. I'm here to help you get better. That's the goal. That's the plan. Right? Keep questioning straightforward and brief. Right? Don't go into an entire life story about trying to assess their lung sounds. Get in there and check them. Let them know. Gain consent prior to doing it. Right? You need verbal consent to touch a patient. Use of hand gestures may be helpful as well. providing the hospital and the advance notice if there's a non-English speaking patient will be arriving. They have to get certain devices out that have interpreters to be able to do a proper assessment. Use pencil and paper, whiteboards, whatever it takes when it comes to hearing impairment, and you need to speak slow and clearly so they have the ability to read your lips. So the purpose, sorry, I told you to take a 10-minute break. So why don't we come back at, let's say, 8:28, we'll come back at. And we'll finish up the rest of the lecture there. Hopefully we'll be done by 9:15 or so. See you guys in 10.
This conference will now be recorded.
Excuse me. All right, so let's talk about the secondary assessment. So the purpose of the secondary assessment really is to obtain vital signs, perform the systematic physical exam of the patient. So if the patient is in stable condition, has an isolated complaint, the secondary assessment may occur on scene. Like if they have just a knee injury, something simple. If not, it's performed in the back of the ambulance en route to the hospital. At minimum, we need to assess and document the following: level of consciousness, respirations, pulse, blood pressure, skin condition, blood glucose, pulse oximetry. I'll even throw in there end tidal. Physical exam may be head to toe, full body exam, or an exam that focuses on a certain area or region of the body. If all they have is abdominal pain, and there's a simple medical condition, do I need to do a full rapid head to toe assessment? No, we can do a focused, right? So the integral part of your physical exam is to compare findings on one side of the body with the other. So if you have leg swelling, you can compare one side to the other. If you have arm deformity, you compare one side to the other. Clavicle injury, one side to the other, to kind of see where the deformity actually is. On some occasions, it may be helpful to even note odors during an exam. Odors can indicate infection in certain medical conditions and also scene safety threats. We're going to assess vital signs using the appropriate monitoring devices, right? Remember that these devices are subject to limitations and mechanical failures, so it should never replace your comprehensive assessment of your patient. Pulse oximetry, being one of them, evaluates the effectiveness of oxygenation, useful assessment tool to determine the effectiveness of oxygen therapy, bronchodilator therapy, and artificial ventilation. Do not use the device with hypoperfusion or known anemia, because again, inadequate readings, cold extremities, or carbon monoxide or exposure to other toxic inhalants that could attach to the red blood cells. Non-invasive blood pressure management, or a blood pressure cuff. Other methods, you can do auscultation, listening through a stethoscope, palpation, checking a radial pulse and checking a blood pressure that way, getting a systolic blood pressure. Electronic measurement. Remember that electronic devices are prone to inaccurate readings in moving vehicles, noisy environments, or if the cuff is not correctly sized or placed on the patient. Always take the first set of vital signs manual regardless of the availability of electronic devices. End-tidal carbon dioxide, determine oxygen consumption, measure carbon dioxide and CO2 levels. CO2 is the byproduct of an aerobic cellular metabolism that reflects the amount of oxygen being consumed. End-tidal CO2 is measured or detected by utilizing capnography or colorimetric type device. What you're seeing over here on the right-hand side is what they call a colorimetric device, or colorimetric. These are utilized for like king airways, intubation tubes, to make sure that they are actually truly in the trachea. They're actually getting an off gas. We always used to say back in the day, yay for yellow, because yellow was good, purple is bad, right? The best way to do it though is waveform capnography. As you can see on this LifePak 15, the very bottom row, that's your waveform that you're looking for, right? Capnography consists of a disposable electronic device that provides means of measuring CO2 output. It can be measured either via mainstream, so utilizing it on a king tube or an intubation tube of some sort, or it can measure through a nasal cannula through a nasal cannulation device. End-tidal carbon dioxide is the partial pressure or maximum concentration of carbon dioxide at the end of an exhaled breath. So if you're looking at the screen over here, I'm sorry, the picture on the left-hand side, you'll see it go over, the breath comes out. At the end of breath, and right where the arrow is pointing now, that is end tidal. That's when you get your reading. The use of end tidal CO2 detector is an essential method for confirming and monitoring advanced airway placement. The absence of CO2 may indicate an endotracheal tube is in the wrong position or the wrong hole, or there is an absence or decrease in level of carbon dioxide in the lungs. When cardiac output increases, the end tidal measurement shows an adequacy of ventilation and circulation. That's what we're looking for. Blood glucose, measure glucose levels in the bloodstream, right? Blood glucose meters are designed for capillary blood, not venous blood. Now, a lot of us do that. We'll pull it off the IV catheter. That's not what they're really designed for, right? They're really designed for capillary blood. Systematically assess the patient in a full body exam, with our goal of doing the full body exam is to identify hidden injuries or unidentified causes, head to toe assessment. Any patient who has sustained a significant MOI, is unresponsive, or is in critical condition should receive a full body exam after life threats have been managed. To perform a full body exam of a patient with no suspected spinal injury, refer to your textbook to Skill Drill 10.3. This will show you how to utilize a exam without a spinal injury and with potential for a spinal injury. Again, these are all things that we will be covering in person. Systematically assess the patient on a focus assessment or generally perform on patients who have sustained non-significant MOI or a responsive medical patient with a specific complaint, right? If a patient's out jogging and they roll their ankle and they call for an ambulance, right? I'm not going to start doing a full assessment on their chest and their back and their spine and all that, when all reality is they roll their ankle, they sat themselves on the ground, and that's my problem, right? So focus attention to the immediate problem at hand. As far as respiratory system goes, look for signs of airway obstruction and trauma to the neck or chest, right? Look for tracheal deviation, any kind of jugular vein distension. Expose the patient's chest and inspect for overall symmetry, equal rise and fall, looking for clear bilateral lung sounds, good movement of air in and out. Rate, rhythm, quality of the respiratory system. Measure that rate, chest rise and fall. Measure the effort, right? Is the rate regular? Is it irregular for breathing patterns? Is it too fast, too slow? Deep breaths, shallow breaths? What's causing this to happen? And look beyond that to see. The presence of subcutaneous emphysema and any other abnormality found is bad, right? Rice Krispies under the skin. It means we have air leaking. The normal resting respiratory cycle, or respiratory rate for an adult is 12 to 20 breaths per minute. So you want to check respirations in a responsive alert patient without making the patient aware what you are evaluating. Because if you start evaluating a patient and saying, I'm going to check your respiratory rate, it's going to screw them up. They're going to try to say, oh, what's normal? They start screwing up the respiratory drive, right? Check your pulse at the same time, count your respirations, okay? I'm going to check your radial pulse really quick. And really, you're measuring respirations instead, right? As far as quality of breathing, we want to make sure you take a good listen to the lung sounds, right? On each side of your patient's chest. I'm going to show you guys on the next slide on lung sounds, right? Decreased or absent breath sounds on one side of the chest and decreased movement of rise and fall would indicate inadequate breathing, which also could indicate a pneumothorax, okay? So normal breathing is silent. If an upper airway has a mild obstruction caused by a foreign body or swelling, you'll hear stridor. Stridor is an upper airway problem, not lower, upper only. If you can hear bubbling, gurgling in the upper airway, the patient probably has fluid in the passages. It does not mean that it's in their lungs. It means it's their upper airway fluid in the passages. They might be able to just cough it up and be perfectly fine. So how do we assess lungs? Okay, roll the patient to their side. If they're lying down, you can have them sit up. And you're going to check right to left. If you do down one side and down the other, there's nothing to compare lobes to. So kind of like an S pattern or a Z pattern, I go across. There we are. We go across over here. Then I come down, go back across, down, back across, like an S pattern or a Z pattern, whatever you want to utilize. Just don't go down one side and down the other because you really can't compare lobe to lobe, height to height, and try to find out where fluids may be actually located. Auscultate over the upper lungs, 1 inch below the clavicle, mid-clavicular line, mid-lung fields, and lower lung mid-axillary line as well. What we're looking for are breath sounds. Normal breath sounds can be clear, relatively quiet. Wheezing would have a high-pitched whistling sound, which suggests an obstruction or a narrowing of the lower airway. You would find this in more of your COPDers, asthmatics. Crackles, moist crackling usually indicate usually inspiration or expiration. If you start hearing crackles, you start thinking either pneumonia, if it's more specific to one side or the other. You can have crackles in or bronchi, but if it's bilateral crackles, lower bases, we are sort of thinking CHF, pulmonary edema. If you have bronchi, which are continuous sounds in the lower pitch of the rattling quality, this is indicative of fluid in the larger airways of the lungs. It could be more of a pneumonia, so obviously you can check for a temp. The temperature is not the end-all be-all for pneumonia patients, right? But they can have walking pneumonia and just have pneumonia with no fever. Stridor is more of a brassy crowing sound. You'll see that in patients that have narrowing or swelling or obstruction in the upper airway, like a foreign body airway obstruction, or it could be something like croup in a child, and things like that. So you just got to pay attention to those. Pleural friction rubs are a squeaking or a grating sound that occur when pleural linings rub together. So a patient who coughs up thick yellow or green sputum most likely has an advanced respiratory infection. Patients with a chest injury may cough up blood or frothy white or pink sputum caused by blood and fluid mixing with the air in the lungs, in the alveoli, and then we start coughing stuff up. A patient with heart failure may also cough up frothy sputum as well, and that means they're having left-sided failure, causing a backup into the lungs. Fluid starts building up. These patients need CPAP. These patients need nitrates. We've got to make that opening bigger, a bigger container, so the CPAP pushes the fluid out. The nitrates make the container bigger, causing vasodilation. Therefore, in turn, will allow for fluid to dissipate out of the lungs, right? If the patient is in CHF and they cannot maintain their own airway, they're altered, then we have to go to a BVM and call for ALS, so they probably end up needing to be intubated. So the depth of breathing, or the amount of air the patient exchanges, depends on the rate and the tidal volume. Remember, the tidal volume is the amount of air in milliliters that is moved into or out of the lungs during one breath. That is tidal volume, right? What is the average tidal volume for an adult? Of how many mLs of air? What do we got for a number? Yep, 500 mLs. Yep, good. We're almost done. We're still early, by the way. So shallow respirations indicate decreased tidal volume. Deep respirations indicate increased tidal volume, right? So you may see this stuff in like Kussmaul respiration, things like that, in diabetic ketoacidosis, which we'll get into when we start talking about endocrine. So the cardiovascular system, we're going to check for abnormalities in the thoracic region. Listen for breath sounds, look for trauma of the chest. Consider the pulse and respiratory rate and the blood pressure. Okay, take all that stuff into consideration. And pay particular attention to rate, rhythm, and quality of the pulse. Look at the skin, take a reevaluation. Check and compare distal pulses. Auscultate for abnormal heart tones. Are they S1, S2 sounds? That's normal for us. The lub-dub, that is normal for heart sounds. Normal resting pulse rate for an adult is 60 to 100 beats per minute. You will see this on a test, and you will have to know this for cardiology when you start looking at rhythm interpretation, right? In an adult patient, if the pulse is greater than 100, it's considered tachycardic. If it's less than 60, it's considered bradycardia or bradycardic, right? And if it's normal, we'll talk about normal sinus, sinus tach, sinus brady. We start getting into rhythm interpretation and recognition. As far as pulse quality goes, we have strong, which is a normal pulse. Bounding is described as a stronger than normal pulse. And then we have the ones that you feel that are weak or feel like weak or thready. So the pulse rhythm really determines whether the rhythm is regular or irregular. And if it's irregular, is it regularly irregular or irregularly irregular? Irregularly irregular would be more like atrial fibrillation versus regularly irregular, which would be more like your PVCs could throw that in there, or if you just have like a sinus arrhythmia of some sort. So rhythms are considered irregular if the heart periodically has an early or late beat, or if the pulse beat is being missed. And those would be more of your heart blocks and things like that as well, which we will not be covering at the advanced level. Blood pressure is the circulation of blood against the walls of the arteries. Remember, we have systolic and diastolic. So things to remember, though, is loss of blood or its fluid components can cause a decrease in pressure, or a loss of vascular tone or a sufficient arterial constriction, right? So patients that are anaphylactic reaction can have a decrease in blood pressure, right? Hypovolemic shock as well, right? Lack of volume or vasoconstriction, where we start causing vasodilation causing blood pressure decrease. I mean the constriction, I apologize. Vasodilation causing that, where we start constricting blood vessels utilizing epinephrine to increase that blood pressure. Cardiac pumping problems or cardiac, like a cardiogenic shock as well, or overdose on beta blockers or other kind of antiarrhythmics like calcium channel blockers and things like that, or antihypertensives medications can also cause a decrease in blood pressure. That's why it's so important to look at their medication list. As shock progresses, blood pressures will start to fall. We start getting into our decompensated shock. Any patient that has a remarkably low blood pressure has an adequate pressure to maintain proper perfusion of all the vital organs. That's when we look for our mean arterial pressure of being less than 64. Are we at that point where our body is no longer having the ability to perfuse? Systolic blood pressure is increased pressure caused along the artery in which, with each contraction of the ventricles, at the pulse wave that it produces. So diastolic pressure is the residual pressure that remains in the arteries during the relaxation phase of the cycle of the heart. So we have a patient that's hypertensive. When your body is at rest, your vessels are at rest, it's still higher than 80 millimeters of mercury, okay? We want to make sure that it's lower or 80 or lower, less than 100 is really good. And then over 100 is really bad, right? It means that the vessels are no longer allowing to have rest. They're still under constant pressure, which then in turn can cause what to happen? What can happen if you have high blood pressure? They can pop.
Okay.
Yeah. Stroke, right? Congestive heart failure. A lot of things can happen. Pulmonary edema. These are patients that are usually very hypertensive. Avoid taking a blood pressure on the arm if the patient has an IV site, a central line catheter report, a dialysis fistula or shunt, had a mastectomy on that side, or injury to the arm. Most EMS agencies carry at least 4 sizes of blood pressure cuffs, from obese down to infants. If the cuff is too small, it may result in a falsely high reading. If the cuff is too large, it may result in a falsely low reading. How can that be dangerous for us? Why would it be dangerous to get falsely high or low readings? Meds. We're going to start treating these patients based on our signs and symptoms, right? Looking at our entire thing, vital signs and all, right? So we're going to start following steps for auscultation, which will cover all palpation and all that stuff. We should already, right, exactly, Tundra, basing our procedures and meds on inaccurate data. We need accurate data to treat our patients. Absolutely, 100%. So as far as the neurologic system goes, we need to make sure we do a decent neurologic assessment. That should be performed on any patient that has a change in a mental status. Evaluate the LOC and orientation to determine the patient's ability to think. Right? Person, place, time, and events. Use the AVPU scale to determine the patient's mental status. Alert, verbal, painful, unresponsive. We're going to consider the following questions to help assess the neurologic system. What is the patient's activity level? What is the patient's mood and thought content? What do the patient's facial expressions tell you? Is the patient angry, fearful, depressed, anxious, restless? Does the patient appear to be uncomfortable? Does the patient make incomprehensible or understandable statements? Is the patient's memory affected? Does the patient remember who family members are? Who is this? Who is that person there? What is the patient's perception or view on what has actually happened? I had a patient yesterday that truly believed that they were in a hospital when they were not. They were home. They were altered. What is the patient's perception or view? Again, inspect the head for trauma. Pulse, blood pressure, skin changes may also indicate hyperperfusion of the brain. Look at all your data. Like Tandra mentioned before, we have to have accurate data to come up with a differential diagnosis to treat our patient. Quickly assess for any loss of sensation by touching the distal portion of the extremities. Get a GCS score. Assess for any gross neurological deficits. Right? Touch one side of the face or the other. We talked about the cranial nerves, right? That's all part of a neuro assessment. Can you feel this and can you feel this? Does this feel the same as this side? Shrug your shoulders. Shrugging your shoulders checks your accessory nerve, right? So there's different ones that we can utilize for different testing to make sure that our brain is functioning appropriately. Detailed neuro assessment. Looking at pupils. They're supposed to be equal, round, and reactive to light and accommodation. Okay? Checking pupil sizes. If the pupils are dilated, what would I expect it to be? What dilated pupils do?
Larger than average.
Right. But what would indicate that? We know they're larger than average. Our average are around 4 millimeters. Let's say there's 6.
Different types of drugs or medications.
Yeah, or death. Death can cause dilated pupils as well. Also assume that the patient has depressed brain function if the pupils are fixed. What if they are dilated and fixed? No reactivity, right? Dilate with the introduction of bright light and consistent with the light when it's removed. That's how we check for that. What if they become unequal?
Head injury.
Or stroke, head bleed, right? So that become unequal in size. Some patients, so some of the, well, I got a question here. Yes, with mismatched pupils. And it's, oh my God, what is that called? Huh, I'm drawing a blank. It's called something. I can't think what it's called. When you're born with unequal pupils. There's a specific name for that. Anybody else have it? It's definitely something. And I have a friend that actually has that. And I love bringing him to classes because people do a pupil assessment. They go, oh my God, you have a head bleed. And really they don't. It's called, yeah, I believe that's what it's called. I'm just drawing a blank of it. I can't think of it.
My son has had unequal pupils ever since he had lidocaine toxicity. His
Wow,
pupils never get back to normal.
interesting.
That's been
Anoscoria. That's what it's
like
called. Thank you, Mike.
it's been like 7 years almost, and he's just always had unequal pupils ever since.
That's crazy. It's amazing what medications can do to the body. Some other causes of, or the MDMA side effects. So some of the causes of depressed brain function also include injury to the brain or brainstem, trauma, stroke, tumors, inadequate oxygenation or perfusion, or drugs or toxins or CNS depressants as well. So as you can see here, pupils equal, round, and reactive to light and accommodation. PERRLA is the useful guide in assessing pupils. We're going to assess neurovascular status by checking for bilateral muscle strength and weakness, and also complete a thorough sensory assessment, right? So again, feeling one side of the face to the other, because this feels the same as this. We're going to check, is it sharp or dull? Using a sharp object to each hand, can they tell the difference? Please do not use a catheter and poke them through their hand. Use a pen tip or something like that that's sharp enough that's not going to hurt them. They should be able to tell the difference between sharp and dull. We're looking at anatomic regions as part of our assessment goes here. Then we're going to do the head, neck, and cervical spine, and inspecting for abnormalities of the head, neck, and cervical spine. Gently palpate the scalp and skull for any pain, deformities, tenderness, crepitus, or bleeding. The patient's face for the presence of a rash, petechiae as well. So what we're looking for is really palpate on your way down. Check the orbits, check the maxilla, check the zygomatic, okay? Check all the different bones, push on them, right? Not super hard, but look for any kind of crepitus. When you get to the neck, we're going to check for tracheal deviation, JVD. Check the cervical spine out back. If you feel any deformities, note it. Any step-offs, note it. Apply a cervical collar. Assessing the patient's eye, looking at the color of the sclera, right? If the sclera is yellow, what would that be?
Jaundice or hepatitis.
Right. Some kind of liver disease of some sort, liver failure, right? So check for foreign objects and blood in the eye, bruising, discoloration around the eyes or behind the ears. What if you have bleeding out of the ears? What would that indicate?
Skull fracture?
Yeah, probably, right? You know, if we have battle signs, what would that be? More
Or brain
specific.
injury?
Yeah, more specific. What type of fracture would it be?
I can't remember.
Okay, the basilar skull fracture. If you have a basilar skull fracture, what type of airway is contraindicated?
MPA.
NPAs, exactly, right? So all this plays into part of our assessment. Checking the patient's ears and nose for fluids. Before opening the patient's mouth, check the upper and lower jaw. Make sure it's not fractured, right? Open the mouth and looking for broken or missing teeth. Note that. Where did the teeth go? Did they swallow it, causing an airway obstruction or not? Odors such as a strong alcohol or fruity odor suggest the need to check a blood glucose level. What would cause the fruity odor?
A high blood sugar.
High blood sugar. Matt O'Connor said diabetic ketoacidosis. Correct. But what does that smell from? The release
It's
of
from all the ketones being burnt off.
absolutely, right? Then we're gonna start seeing them in like cruise mall respirations because they're trying to blow off their gases, right? That's what's going on here. These patients here need IV therapy. They're gonna probably need some insulin at some point in time. Then IV fluids will help reduce that and dilute the blood. That's what we're gonna do in the field as AEMTs. So check a blood glucose. Check for the neck for bleeding, swelling, palpate for signs of trauma. Feel the trachea. Subcutaneous emphysema or crackling sound produced by air bubbles underneath the skin. So we're going to also inspect for pronounced or distended jugular veins, right? What would cause jugular vein distension?
It's normally respiratory, isn't it?
Not necessarily respiratory. It's a cardiac issue.
A blood clot.
We have Mike Hunter saying heart failure. Yeah, right-sided heart failure can actually cause that, but Matt O'Connor got it. Tamponade, cardiac tamponade, right? That'll cause jugular vein distension and two other things, right? So Matt got the tamponade part right. Somebody else answered that. Jugular vein distension, and there's two others with it. We've covered this before. Cardiac tamponade. Hard to squeeze it,
So
right?
somebody said muffled heart sounds, but it's narrowing pulse pressures too, isn't it?
It is, yeah, correct. Narrowing pulse pressures, muffled heart sounds, JBD. That's known as what triad? Bex. Yep. So Bex triad. Pick up on this stuff. Very important. Look at the chest. Inspect and visualize and palpate over the chest area for injuries and signs of trauma. Hands on the chest, palpate, up and down, rise and fall, equal bilateral. They're going back and forth. Is there any paradoxal motion associated with a fracture of several ribs? Looking for crepitus or flail segment. When palpating the chest, note any crepitus, which is indicative of a fractured rib. Note where it's located. Palpate the chest for subcutaneous emphysema. If you start feeling things pop underneath your fingers like Rice Krispies, we have an air leak. Auscultate breath sounds. Check everything, right? We're looking for absent breath sounds on the trauma patient. Is there a pneumothorax? We're going to palpate the abdomen, right? Umbilical, that's the center. Right and left, upper and lower. Palpate. Two hands, push and feel. Visually inspect. Do I notice any bruising? Right? If you have bruising on the flank, what is the other name for that? Bruising on the flank is called what? Almost there, guys. Almost there. So bruising on the flank is called Gray-Turner's sign. Okay? Yeah, there you go. If you have bruising around the umbilical or the umbilicus, what is that called? It's called Cullen's sign, bruising around the umbilical area, right? If you have significant pain in the right lower quadrant, You palpate, what potentially could that be on a medical patient?
Appendix.
Appendix. And what specific point is that called again?
What did you just say, Kev?
What specific point is that called? What's another name for it?
McBurney's.
McBurney's point.
The Bernie Mac point. Got it. Right? McBurney's point. So visually inspect, palpate. You have to palpate this. Right? Where's your liver located? What quadrant?
Lower right.
You got the right side. Go up a little bit higher though.
Upper right.
Upper right, yes. Perfect. Upper right quadrant. And as we're palpating it, we should be able to feel on a patient's exhalation, okay? What you do is you take your fingers and you find the rib cage and you hold it in the upper right quadrant, right? Underneath the ribs. Deep breath in. As they exhale, wrap your fingers underneath the rib cage a little bit. You should be able to feel 2 centimeters of the liver. If it's more than that, it could be an inflamed liver of some sort, okay? One of the first indications of a pediatric and heart failure, pediatric, is an inflamed liver, right? So pay attention for that. Bruising over the flank area suggests blood collecting in the retroperitoneal space, okay? What organs are located retroperitoneal? Kidneys, pancreas, right? The kidneys are definitely more retroperitoneal though, okay? We got to watch for those. Right, asymmetry may suggest a swollen organ immediately under the area that you find it. Severe distension may be caused by fluid in the peritoneal space, which is what they call ascites, which is usually blood, as in a slow leak from a rupture, obstruction, or a bowel blockage, or an infection like sepsis. We want to palpate the abdomen, evaluating for symmetry, masses, tenderness, and bleeding. I look for pulsating masses and palpable masses. If I push on the umbilical area not too hard, and I feel a bounding, pulsating mass, what would that be?
AAA.
AAA. There's enough things I want to burst in the back of an ambulance. Patients have a 5% chance of survival even on the OR table if one of those bursts, right? Not much. Always start the palpation of the abdomen in the quadrant that is farthest away from the patient's pain or obvious injury, right? And work your way towards it. Assess for the presence of rebound tenderness as well, right? And you'll have patients with appendicitis of significant rebound tenderness. Expect the pelvis for symmetry, instability, and pain, tenderness, crepitus, bleeding, deformity, and any other obvious signs of injury. If you feel crepitus or deformity, splint it. If the patient has no pain, gently press downward and inward on the iliac crest of the pelvic bones. Do not rock the pelvis. That's a chance to have your book open up to an open book fracture. Arteries can be severed. You bleed out, you die, right? No rocking of the pelvis. Inspection of the pelvis area is not often done in patients with medical emergencies, except when the pain and bleeding is present. In female patients, determine whether the bleeding is coming from the vaginal opening, urethra, or female external genitalia, or rectum. We have to know. In male patients, it's essential to determine whether the bleeding is coming from the urethra or the rectum itself. We have to know where the blood is coming from. When we assess our extremities for musculoskeletal injuries in the system, it's typically done because of the chief complaint associated with some type of trauma or due to the MOI, right? When you're palpating the extremities, it's not a light touch. Grab a hold of the bone and move the bone to see if it's actually fractured, right? Get a hold of it. You're looking for decap BTLS in all your extremities. Check for pulses, motor function, and sensory, right? I don't care if you want to call it CSM, PMS. I would just recommend you're not telling a female patient you're assessing their PMS. You're probably going to get pissed off. I would use CSMs, right? Inspect each extremity with decap BTLS. Check for distal pulses on the foot and the wrist. When you find a tibial pulse or a dorsal pedal pulse, use your pen and mark where it's located. That way you don't have to go trying to find it again. You have an idea of where it's located the second time. You're going to have to do a reevaluation. Palpate each extremity individually. Please not do them at the same time. Right? Also check, again, CSMs, push down, pull up, sensory, sharp or dull. Which toe am I touching? Motor function, wiggle your toes, move your feet. Go through the process. Note the color of the fingernail and fingernails, or the fingers and the nail beds as well. As far as the posterior body, when you log roll on the head, 1, 2, 3, roll, we're going to palpate from C3, because you're not going to be able to feel C1 and C2, right? The atlas and the axis, but you're going to use C3 all the way down to the coccyx, okay? And go down slowly. Look for any step-offs or deformities, and then note it where it's located. Additional exams would be if time permits or during the transport. You may decide to perform a focused assessment on each body system. Remember to ask 2 questions. What additional problems can be identified through this exam, and how will these findings change my treatment choices? Right? Actions you may need to take as a result of finding include the following: addressing any potential life threat conditions, establish spinal motion restriction if the neck or back pain is abnormal, and sensation or movement is identified in relationship to trauma. We're going to modify any treatments that is underway on the basis of any new information. Initiating treatment for additional problems identified during the focus exam, or modifying transport decisions to a more appropriate facility. Do they need to go to a trauma center? Do they need to go to a facility that has urology? What specific facility do they need to go? And can we get there in a decent amount of time, not to delay patient care? Is the patient status 1? Do they have to go to the closest hospital to stabilize and they can call a transfer company? Or can we bypass and get that patient to definitive care as long as they're stable enough to make it? Stability is based on blood pressure, airway management, right? Things like that, right? Not the fact that they have a broken ankle and they're in a lot of pain, right? Depending on the traumatic injury that's actually there. Is their instability going to kill them? Is it a life-threatening emergency? Then we're going to get into our reassessment, which is performed at a regular interval during the assessment process, looking at ABCDEs, LOCs, level of consciousness, baseline assessment, reassessing every 5 to 15 minutes. Compare the baseline vitals obtained during the primary survey with all subsequent vital signs. This is what they call trending. I'm looking for those trends to see if what we are doing in the back of the ambulance is making the patient better, or are they getting worse? Do we need to tailor our assessment and our treatments to make the patient better again based upon what's not working? Monitor skin color and temperature because things can change quickly, and reassess the blood pressure and pupils. End tidal CO2 is going to be your friend. Remember, it's live in time, off-gassing the patient, monitoring respiratory drive and everything. It will pick up apnea if a patient stops breathing faster than a pulse ox will actually drop. And that is fact. And if you have it back at your station, you want to try it out, put end tidal nasal cannula on yourself. Put a pulse oximeter on your finger and hold your breath for 30 seconds to a minute if you can, and watch what happens to the monitor. I can bet you right now that the end tidal will drop to nothing. It'll show you you're no longer breathing, an apnea alarm will go off, and your pulse oximetry will still show 98%. Because it takes longer for your body to recognize through red blood cell transportation that your oxygen levels have dropped. And at that point in time, 5 minutes later, it could be too late. It's a good drill to try when you go back to your station. Try it out. I'm telling you, end tidal is the way to go. So reassess the chief complaint in light of treatments provided thus far. Ask and answer the following questions about the patient's chief complaint. Is the current treatment improving the patient's condition? Has an already identified problem gotten better? Has an already identified problem gotten worse? And what is the nature of any newly identified problem? And does that need to be addressed now? or can it wait till we get to the hospital based on time? Recheck interventions, reevaluate. Management of ABCs is very important. All right, if we start losing the airway, we need to start fixing the airway. ABCs. Ensure adequacy of interventions and consider the need for new ones. Right? Thanks, Rosa. We have one more slide left, anyways. After this, so again, if you do an IV and you're giving fluids, double check your site because blood pressure cuffs, bumps, things can infiltrate. And if you start noticing increased swelling around the area, stop the infusion. You've got to pay attention to your sites. And to finish off, identify and treat changes in the patient's condition. Reassessment is necessary to help monitor changes in patient's condition. Right? Remember, unstable every 5, stable every 15. Right? Let me stop the presentation here.